We'll be starting with histoplasmosis. So we are currently running through the fungal infection. So histoplasmosis is, one of those fungal infection that is caused by Histoplasma capsulatum, which we all know. And there are some common risk factors, and that includes HIV, people that explore caves, or people that are exposed to bird and bat excreta. So most of these birds and these bats live within the caves. And you typically find, the organism usually in area of Ohio or Mississippi. So that we can further see that in the question step. So that can further reinforce our diagnosis. But one thing to also take note of here is that majority of the symptoms of histoplasmosis, you won't see it until the person starts having some form of immunosuppression. So it's very, very common in people that are immunosuppressed. So that's why having HIV/AIDS, it's a very significant risk factor. So most of the time, if somebody is exposed to it and the person is immunocompetent, that is symptomatic, or they can just have flu-like illness. But for people that are immunosuppressed, they can have variety of presentation, and majority of it, they are going to have presentation in line of pneumonia. So you just have cough, fever, and don't forget the nature of the cough is going to be non-productive. If you don't know anything, let us hold on to that. Anytime we say a cough that is not productive, think about, maybe pneumonia from atypical organism, like maybe a fungal infection, a viral infection, or those Mycoplasma, Legionella, and the likes. Whenever you are saying productive cough, know that it's from the typical organism, like maybe strep pneumo, phleb, Staph aureus, and the likes. So back in our step one, we used to use an acronym to remember the presentation of histoplasmosis, and that is the word horse. That's what we used to use there. And H is standing for hepatomegaly. So they usually have hepatosplenomegaly. The O is standing for the oral ulcers. The R is standing for the rash, which is erythema nodosum. The S is standing for splenomegaly. And the last E is standing for erythema nodosum, which is just similar to the R. And in addition to this, they usually have features of bone marrow suppression. So they can have fever, weight loss because of chronicity, hepatosplenomegaly, lymphadenopathy, non-productive cough, just features of pneumonia, non-productive cough, fever, weight loss, then some extrapulmonary symptoms like hepatosplenomegaly, the oral ulcers, the palatal tongue ulcers, and of course the bone marrow suppression causing pancytopenia. That's just all what you need to remember for histoplasmosis. So how do you make the diagnosis? If you request for a chest x-ray, we can see a variety of presentation. So we could see like diffuse nodular density, focal infiltrate. We could just see like cavitary lesions. But all these things doesn't typically tell us, what is happening. Somebody can have tuberculosis and have this. Somebody can have miliary tuberculosis and they can have diffuse nodular density. So we don't actually know if it's tuberculosis or histoplasmosis or something else. So in addition to doing our X-ray, we can further confirm that diagnosis, by doing a urine or serum polysaccharide antigen test. So take note of the word urine. So two common organisms that they use urine, test to make diagnosis. Legionella is one, histoplasmosis is another one. So you do the urine or serum polysaccharide antigen test, to make your diagnosis, especially for the disseminated form. So you can also use it to monitor response to therapy and also to make diagnosis of relapse. And sometimes you can do staining, of um, any sample that you have obtained. Probably you obtain it from a bone marrow, from a lymph node biopsy, or from a liver sample, or even from a bronchoalveolar lavage. You can stain it, fungal staining, silver stain. And what do we expect to see? We expect to see like the yeast in the macrophage. So you can see this macrophage here, mononuclear macrophage. This is the macrophage. Of course, macrophages, monocytes, they are mononuclear. So once you are seeing one or two nucleus, you know that's not a macrophage. That's likely going to be like maybe neutrophils, eosinophils, or basophils. So this is a macrophage now, and surrounding the cytoplasm of that macrophage, we can see numerous yeast, which are smaller relative to that macrophage. So that's um, histoplasmosis yeast we are seeing. And they can further help us and tell us that the yeast, they have a narrow body. So narrow body yeast in macrophages. Think about, think about histoplasmosis. So they infiltrate the macrophages. How do you treat? So if the person is having like a mild pulmonary disease or disease that is stable, that is not causing much problem, the nodules in the lungs are just stable. The person is just having like flu-like illness, you might not do anything. Just treat supportively, provided that person is immunocompetent. Of course, because the person is immunocompetent, that's why they are going to be having like mild pulmonary presentation. But if we don't see supportive treatment the option, just go for itraconazole. It's as simple as that. So people with chronic cavitary lesions, so they tell us we do the X-ray, we are seeing a lot of cavities. So it means that something, chronic has been going on in that lung. So you might want to halt the process by giving itraconazole for at least a year. So for chronic cavitary lesions, give itraconazole for at least a year. But if the person is having like a severe acute presentation, or you notice that that presentation is disseminated, is already getting to the liver, getting to the bone marrow, getting to the lymph nodes, getting to the mouth, disseminated presentation, you might want to give something more active, and you introduce your IV liposomal amphotericin B. So you can do that for 2 weeks, and then follow it up with itraconazole as if you want to manage it, as a chronic problem. So you maintain with itraconazole for at least 1 year. So don't forget, if person is having like mild disease, no much problem, supportive treatment. If you want to give something, give itraconazole. If there's cavitary lesions there, give itraconazole for 1 year. If there is active presentation, person is actively coughing, we are seeing like disseminated feature, bone marrow involvement, you have to give amphotericin B that you maintain with itraconazole. So this is nocardia. Of course, remember nocardia from our step one. It is one of those partially acid-fast gram-positive rods, that can cause CNS problem. It can cause cutaneous problems. It can also cause pulmonary problems. In fact, you might not be able to tell between the pulmonary presentation of nocardiosis and tuberculosis. They'll be virtually the same thing, until we do our gram stain and we are seeing this, branching filamentous rod. So that could increase our suspicion for the potential for nocardosis. So how do we treat nocardosis? We remember the SNAP in our step one, which is SNAP. So S is for the sulfamethoxazole, which is Septrin for nocardosis, and for actinomyces, we give them penicillin. So don't forget, people with nocardosis, they can have problem with the brain, they can have meningitis, encephalitis, they can have, chronic pneumonia, and they can also have some skin lesions. So moving on to the next one, which is coccidioidomycosis. So this one is endemic to the southern western United States, like in California or Arizona, unlike in histoplasmosis where you have it in Ohio and Mississippi. So this one you find it in Arizona or California. And just like histoplasmosis, people that are immunocompetent, they can just have like flu-like illness, but people that are immunosuppressed, they can have like a form of pneumonia, and it can disseminate. Just like histoplasmosis, it can also disseminate to other extrapulmonary sites, like the bone, the CNS, and the skin. Now, this can affect the bone, it can affect the joint, when it affects the joint, they present with arthralgia. It can affect the skin, and it causes similar lesion as what you find in histoplasmosis, which is what erythema nodosum. But in addition to erythema nodosum, it can also form the erythema multiforme. We know the way all these lesions they look like. But don't forget that the commonest cause of erythema multiforme, who wants to remind us? What's the commonest organism that causes erythema multiforme? Anybody?
Is it mycoplasma?
Herpes simplex.
Yes, so it's herpes simplex. Then mycoplasma will now be the second. So herpes simplex is the commonest cause, then mycoplasma is the second, before we think of other things. So, of course, people that have a very high risk of developing these problems, they would be immunosuppressed in a way. Either they are pregnant or they are what? HIV positive. So, the same risk factor as somebody with histoplasmosis, when they go about exploring caves, or probably there's earthquakes that generate some dust, and those dust contain the spore of the fungal and it's inhaled, they can develop the problem. So the presentation is just like acute pneumonia, fever, chest pain, cough that is non-productive. And because it affects the bony joint, they can have arthralgia, you know, um, they can have some bone lesions too, and of course meningitis because it affects the CNS. So the one that commonly affects the CNS out of this chronic fungal infection is coccidioidomycosis. Never forget that. Never forget that. The bone, the CNS, and the skin. The bone, the CNS, and the skin. So in the skin, they can have abscess, they can have erythema multiforme, they can have erythema nodosum. So serology, I don't want us to know anything about serology because most of the time it's not very sensitive. It might not pick it at the early period. But the best test is to do a PCR analysis. If you can't do the PCR, you can do like a stain, like the way we stain for this knockout that I talked about, or the way we stain for histoplasmosis. But here we are going to be seeing like the endospore within the spherus. So let us see. We don't have an we don't have an image yet. So once they tell us that we are seeing like endospores with spherus, we should think about coccidioidomycosis. So let us just remind ourselves the way it looks like. I know that we are all familiar with it from our step one. Endospores, endospores with spherus, spherus with endospores. Endospores, okay, showing endoscope. Endospores. Okay, so this is an example. We can see the endospores. You can see all these circular stuffs. Those are the spheres. So once you see that, it's spherical, endospores. You know, once you see something like this, containing small endospores, call that like spheru containing endospores. So spheru, like a sphere containing tiny endospores. That's classic for coccidioidomycosis. So you can identify that with the KOH or the silver stain. So don't forget the SO5 too. It's very much like that of histoplasmosis. We see the infiltrate, the nodules, the cavities. It's any presentation. And the risk factor is when you get exposed to the caves, earthquakes. You are living in the region, California, and there's a form of immunosuppression, high risk. So just like management of histoplasmosis, if it's acute, what do we do? Acute presentation or disseminated, what do we do? IV amphotericin B needs to be given. So give IV amphotericin B, followed by any of the azole. In histoplasmosis, we're picking itraconazole. We can also use itraconazole here. If it's acute here too, you can do supportive. Sorry, if it's mild rather, you can do supportive or you can place on itraconazole. So it follows almost like similar algorithm. It's mild, nothing much, like nothing really severe, just mild supportively or give itraconazole or fluconazole. But once it's very severe or it is disseminated, introduce your IV amphotericin B and follow up with what? The azole. If it's chronic, so the only difference is that when we're doing the chronic one for histoplasmosis, we said we need to give itraconazole for like a year. But here, you might not give anything. If the person is having asymptomatic cavities or nodules, you might not need to do anything. unless that the cavities are symptomatic and they are progressive, that's when you can now, go and do surgery to remove those cavities and place them on azoles. Don't forget the cavities are potential sites for aspergilloma to form. So the cavities can also rupture and there could be massive hemoptysis. So if it's symptomatic or it's getting too large, please go in and do surgery and remove it. So what about blastomycosis? Blastomycosis is another one, which is found in the central and the southern eastern United States, just like in same site like histoplasmosis, the Mississippi and the Ohio River valleys. So this one typically goes to the bone to the skin to and the prostate. So if you look at the difference between blastomycosis and coccidioidomycosis, both of them affect the bone. There could be some bone lesions, arthralgia and the likes. They affect the skin, erythema nodosum, skin abscess, and the likes. These can also affect the CNS, but coccidioidomycosis have more CNS presentation than this. The one that is common to this one is the fact that it can affect the UTI, the urinary tract. So it can affect the urinary tract area like the prostate, and they can be having features of chronic prostatitis. So you see somebody presenting to the clinic with cough, chest pain, fever, erythema nodosum. They now show us some skin lesion that looks like squamous cell cancer. And the person is also presenting with prostatitis, or to otherwise problem. The answer is going to be blastomycosis. They can further help us, and they tell us that they do a culture. They do a culture of the sputum that was induced because the person was coughing. And they were able to do like a KOH mounting for a silver stain, and they saw broad-based budding yeast, BB, for blastomycosis. BB is always for blastomycosis. Narrow base budding yeast in the macrophage is histoplasmosis. Endospores in spherules is coccidioidomycosis. So don't forget about the presentation. It can affect the bone, arthralgia. They can have UTI symptoms, affectation of the prostate. It can affect the skin. Even they'll be having like chronic abscess, warty-like lesions in the skin, and it can cause meningitis as well. So how do you treat? Once the patient is symptomatic, just go and give traconazole, and of course you have to introduce amphotericin B. Whenever it's disseminated and it's very severe, you always have to give amphotericin B. And of course you continue with the traconazole. And this guy may actually need ICU care because this one looks much more virulent compared to the other ones. It looks very bad. And I'm going to show us a lesion of, how they cause problem to the body. So they can get complicated with ARDS, meningitis, just like we said, or any other systemic infection. So just focus on the result of the culture. It kind of help us to narrow it down. Broad-based budding yeast, BB, blastomycosis. So let us look at the leg lesions we see someone with blastomycosis. So we see the way it looks like. It looks like squamous cell carcinoma that is non-healing. So all these kind of things. So these are part of what we can get in the exam. Just shows something much more chronic ulcerated lesion in the leg like this, and they do like a stain, and we are seeing like broad-based body. So think about the possibility for blastomycosis. Okay, so let us look at some questions before we go further. Yeah. So this is just one or two. We'll move on. So this is a 30-year-old woman who comes to the physician because of dry cough and chest discomfort for 3 days. During this period, the patient has had headaches, muscle aches, joint pain, fever, and chills. 10 days ago, he was hiking with her family in Mississippi. The patient has asthma that is treated with albuterol inhaler. The mother has lung disease treated with methotrexate. The patient has smoked 1 pack of cigarettes daily for the past 10 years. Temperature is 38 degrees Celsius. Physical examination shows slight wheezing throughout both lungs field. Urinalysis is positive for polysaccharide antigen. Microscopic examination of the bronchoalveolar lavage specimen shows macrophage filled with oval cells that measure 1 to 5 micrometer and bored from a narrow base. Culture of the specimen on Sabarodega at 24 degrees Celsius grow molds composed of septate hyphae. Which of the following pathogens is most likely cause of this patient's symptoms? Anybody?
Histoplasmosis.
Histoplasma. So we have everything pointing towards histoplasma here. So don't forget the urine test. And what you are testing for is a polysaccharide antigen. So let's look at this, then we move. A 35-year-old military nurse with Crohn's disease comes to the physician because of 3 weeks history of fever, fatigue, dry cough, headache, and myalgia. During this period, he also had 4 kg weight loss. 1 week ago, he developed several painful oral lesions and difficulty swallowing. He served as a military base in Ohio. Current medications include PRED and infliximab. Temperature is 38.5. Vitals is okay. Examination shows diffuse bilateral crackles, hepatosplenomegaly, and multiple 1 to 2 cm ulcerative lesions with raised border on the oral mucosa. Labs is as follow. Result of combined HIV test and interferon gamma release assays are negative. An X-ray of the chest show hyaline with central calcification and multiple well-defined pulmonary nodules measuring 1 to 10. Which of the following is the most likely appropriate therapy for this patient? Anybody?
Amphotericin B.
Amphotericin B. What's our diagnosis here?
Histoplasmosis.
Histoplasmosis. So everything is pointing towards histoplasmosis. We can see the pneumonia presentation. We can see that the person is having oral ulcer, which is part of the horse. We can see that the person is having hepatosplenomegaly, and there's evidence of affectation of the liver here as well. And the X-ray is also showing like affectation of the lungs, nodular lesions in the lungs. So the only thing that can cause hepatosplenomegaly, pneumonia-like lesions, oral ulcers, in somebody living in, I think they just mentioned where the person is living in. Okay, yes, in Ohio, exactly. In Ohio, it's likely to be. So this is disseminated. So this guy would benefit from, liposomal amphotericin B. Who knows the risk factor here? Many risk factors in this patient. Who can identify them? This person is living in Ohio. What else? Anybody knows anything?
Patient is on prednisone.
He's on prednisolone, and in fact, combining prednisolone with infliximab is a very bad, because histoplasmosis is one of those granulomatous lesions. So if we are now giving infliximab, the granulomas, they would just be disintegrating, and there's going to be a problem. So, let's see. Okay, so I don't think I have. Okay, I think I have one question here. So, this is a 34-year-old man. I need to try to enlarge this. Let me just read it before the thing obstruct again. So, this is the 34-year-old man who comes to the emergency department due to 3 weeks history of fever, night sweat, fatigue, cough, shortness of breath. He has lost weight. He was diagnosed with HIV a year ago and she's not taking the drugs. 3 months ago, CD4 count was 80. The patient was recently moved to Missouri to live with his parents. He does not take tobacco, alcohol, or recreational drugs. There's fever, vitals are okay, and there are small ulcers on the hard palate with multiple enlarged lymph nodes in the cervical and inguinal chains. Pulmonary examination shows scattered lung crackles. The abdomen is soft, non-tender, but there's a prominent hepatosplenomegaly. Lab results show pancytopenia with elevated aminotransferase level. Chest X-ray shows bilateral reticulonodular opacity on with hilar adenopathy. Which of following is the best next step in management of this patient?
Urine histoplasma.
Urine
Urine histoplasma antigen. Okay, I agree with you. Now, because I put it under blastomycosis, some people would think that they'll be looking for something related to. So that's why I purposely do it. So that I want to see if we can actually understand what we are dealing with. So this is urine histoplasma antigen, because everything here is pointing towards histoplasmosis. Which of the following antifungal agent is the best next test for the treatment of this patient? What are we giving this patient?
Amphotericin.
It's amphotericin B. So let's look at this one. A 35-year-old man from Wisconsin comes to the physician complaining of fever, night sweat, productive cough, and unintentional weight loss over the past 3 months. Several days ago, he begins to notice some multiple skin lesions. He has no medical problems and takes no meds. Does not use tobacco. He works outdoor in wood cutting and construction. Physical examination shows a man with medium build in no apparent distress. His fever, vitals are okay, but there are multiple well circumscribed verrucous crusted lesions. X-ray shows upper lobe consolidation with 2 lytic lesions in the ribs. Which of following is most likely cause of this patient's symptoms?
Blastomycosis.
Blastomycosis. So amputation of the ribs is talking about bone involvement. We can see the crusted lesion, verrucous, well circumscribed skin lesions. So that's the skin affectation. And the person is having like a pneumonia-like presentation. So the only thing that can explain everything here is blasto.
I'm from Wisconsin.
And this one, so I don't really know, the geography. So if we know the geography, it further helps us to be sure in the exam. So
See, that's
tuberculosis.
where I live. So I
Yeah?
should.
The what?
I said that's where I live. So
That's right. So you have to be very careful of going to please don't go to the desert. So stay within the town. All right. So tuberculosis. Tuberculosis is caused by Mycobacterium tuberculosis, and tuberculosis is a serious problem, especially in developing and less developed, countries. And there are so many risk factors for tuberculosis. Um, Somebody living in endemic high risk region, like in Southeast Asia, Cambodia, India, Philippines, Thailand, all those parts, and even Sub-Saharan Africa, or people that are homeless, people that are in some form of incarceration, maybe prison lockout, or people that abuse alcohol, people that use drug intravenously. So all this kind of category of people, IV drug abusers, they have a very high risk of being immunosuppressed from maybe HIV, or something. And also people with HIV, people that work in healthcare like us, or somebody with pre-existing lung disease or immunosuppression, or even advancing age. These are the common risk factors for tuberculosis. So almost everybody, particularly from all these countries, are infected with TB in one way or the other. So usually because of the strong immunity, we are all asymptomatic. So I've got that like latent tuberculosis, and some can get exposed to tuberculosis at the first time, and they are going to be symptomatic. So that's going to be like the primary tuberculosis. Why some people they are going to get exposed to it the first time, like majority, and they are not going to be symptomatic. So the infection is going to be curbed. When that curbed infection now reactivates at a later time, you call that secondary tuberculosis. So how do they present? Typically, you have a cough, hemoptysis, difficulty in breathing, weight loss. Anytime we see weight loss, know that it's a chronic problem. It's not likely that we see weight loss and be picking strep pneumo as pneumonia or staph aureus as cause of pneumonia. This is going to be like something like all those chronic pneumonia cause, like maybe the fungal or tuberculosis or even lung cancer. So, extrapulmonary spread of the tuberculosis infection can go outside the lungs. Because typically it affects the lungs, but sometimes it might go outside the lungs, especially in people that are immunosuppressed, and it can disseminate hematogenously to other parts. So there are so many tests we do just to screen for tuberculosis. The Mantoux tuberculosis skin test and the gamma interferon. So now we know that everybody, when they are given birth to, they get BCG vaccine at the left arm. That vaccination can cause a false positive test with the Mantoux tuberculosis skin test. So that's why it's not reliable. So the only way you can be sure that, okay, somebody with the tuberculosis skin test has or does not have tuberculosis is by doing the interferon gamma release assay. That's just what I'm going to say there. So somebody received BCG vaccine and you do Mantoux tuberculosis skin test and it's positive, and you're now saying that the person is having latent tuberculosis. That's a joke, you know. But if that kind of person that has received the vaccine have a positive test with interferon gamma, you can confidently say that yes, that person has a problem. So what is latent tuberculosis? So latent tuberculosis is tuberculosis in somebody that is exposed to the tuberculosis infection, but the person is asymptomatic. Now, to diagnose that, we can use the tuberculosis skin test, which is a Mantoux test, or we can use the interferon gamma release assay. But if somebody has been taking BCG vaccine before, it is best to pick IgRA. So let us pay attention to that in our exam. And I want to say here that in the US, if somebody have latent tuberculosis, you are going to get treatment. And in addition to that, they will go and report you to the state, local health authorities. It is reportable. You have to report it and you have to treat that person. So what are the values for the tuberculosis skin test, for the tuberculosis skin test that we can use to say that, okay, this person has a positive tuberculosis skin test or this person has a negative? So we look at the size of the lesion, and we also look at some background information about the person. So to do the tuberculin skin test, we inject the tuberculoid antigen into the person's skin. I will check back maybe after 48 hours to see if there's going to be any induration. And we measure it. Mind you, we measure the indurated area. We don't measure the erythematous area. Don't extend the measurement to the area of erythema. No. It is the induration area that you are going to measure. Please don't joke with this. So if the value is between 5 to 9, so now we can say that although that is not a very large reaction, but we allow that because we have to 3 spectrum. We have like 5 to 9, 10 to 14, 15. So 15 is a great reaction. It means that that person actually has tuberculosis. That's why this induration area is very large. So people that have like a normal immunity, they are healthy and they have lesion of 15 and more, we can say that this person has and the person is asymptomatic. We can say that okay, this person has latent tuberculosis. If somebody that is having features of the IDP camp, and the person gets a value of between 10 to 14, you can say the person has tuberculosis too. Now, what are the features of the IDP camp that I'm talking about? I stands for intravenous drug use. D stands for, are you a resident of developing country like Ghana, Nigeria, that are prone to tuberculosis? P is people that work in areas where there's clustering, where there's like congestion, like, working in prisons. We are in prison or nursing homes, correctional facilities, all those kind of things. The people that are homeless, if they have value of between 10 to 14, you can say that they have a positive tuberculosis skin test. And one thing that's common to all these people is that most of them, they are sick. IDP people, they are very sick. So anybody with chronic illness, CLD, CKD, chronic lung disease, heart failure, any chronic disease having this kind of value, you can say that they have a positive tuberculosis skin test. Now, the one that you can now go very, very low, between 5 to 9, is someone that have HIV, or the person has been in contact with somebody with tuberculosis. Or when you do chest X-ray, you are seeing tuberculosis. So you do chest X-ray, you are seeing features of tuberculosis. You now go ahead and do tuberculosis skin test. It's now between 5 to 9. You can confidently say that what you are seeing is tuberculosis. So any form of immunosuppression, maybe from transplantation, HIV, contact with TB, evidence of TB on X-ray with this value, you can say this person has tuberculosis. Now, some immunocompromised people might not react very well to the tuberculosis skin test, and that's the concept of anergy, because they don't have any T lymphocyte to mount immune response. So there's a possibility that the TST test is going to be negative, So all patients with, if you do a test for somebody and it is PPD positive, like the Mantoux test is positive, you must, before you now conclude that this tuberculosis is it active or latent, before you conclude, you have to go and look at the chest X-ray, because somebody might not be having symptoms. They might not be having symptoms and they have positive PPD. You don't say that because they are not having symptoms, it's latent. No. Yeah, they might not be having symptoms, but if you do X-ray and you see evidence of tuberculosis on the X-ray, that is still active tuberculosis. So that kind of person should still get treatment. People with latent tuberculosis, there's nothing on X-ray. You won't see anything on X-ray and they'll be asymptomatic, like majority of people. But anybody that is not symptomatic but has X-ray finding of tuberculosis following a PPD test that is positive, you can say this person has active disease. So that is why immediately you do PPD test that is positive, the next thing is to go and do your X-ray to see. Very important. So if you catch somebody that's having active tuberculosis, and that person is chronically coughing badly, or maybe you do PPD test positive, you now do X-ray, you're now seeing feature of tuberculosis, you now need to investigate further. So by doing the first thing is to obtain a gram stain sputum. So you obtain a sputum and you subject that to acid fast staining of the sputum. So you collect 3 samples 8 hours apart to increase the sensitivity. Then after you have done that, you also collect sample for culture and NAAT. So you do 3 things. You collect 3 samples for acid fast stain, collect another sample for culture, which is going to take a long time, and you do another sample for NAT. So this can help you to make the diagnosis, and it will also tell you if that strain is sensitive to rifampicin. If you are thinking of extrapulmonary TB, you have to also obtain sample from other sites. So if the person is having problem at the bone, take a bone biopsy. Problem elsewhere, take a biopsy of that area, do the culture, do the AFB staining to see if there's tuberculosis there or not. So the common presentation in the X-ray of someone that has tuberculosis that is primary is that you could see infiltrate, your opacities in the lower lobe of the lungs. But whenever it becomes activated, and of course, in addition to that, there's going to be calcification of the nearby lymph node, the hilar lymph node, which you call the Gons complex. But if the person gets activated, that cavity is going to move upwards. So if the person develops a secondary tuberculosis, the cavities that we are going to be seeing will be up. And again, we don't even see cavities in the primary. We don't really see cavitary lesions. But in the reactivated one or secondary, we see cavitary lesions at the upper lobe. We know that this is likely to be reactivated tuberculosis, just like we are seeing here. So after we have seen this, we now go and do our culture, our AFB stain, our NAT to make our diagnosis. We can see some tiny nodular lesions in this person. So this guy is actually having miliary tuberculosis. Once we see this, we know that we can be rest assured that this person has already disseminated the tuberculosis strain into the blood. You can find it elsewhere for it to be having this millet appearance. So, how do you treat somebody with tuberculosis? Don't forget, both latent and active tuberculosis must be reported to the local and the state health departments. Very important. And don't forget, people with tuberculosis, you want to take airborne precautions. You want to take airborne precautions. So, you want to sorry about this. So you want to take airborne precaution, wear the N95 mask, wear PPE, and stand at least 6 feet from anybody that is having tuberculosis. You have to pay attention to the airborne precautions. And how do you treat? So people with latent and people with active, both of them will get treatment. So somebody with latent tuberculosis, you give them, you can use both of them, isoniazid and rifampin. If you are combining, you are going to treat them for shorter time. So if you are adding isoniazid with rifampin, you are going to treat them for only 3 months. If you are using any one of them singly, it's going to be more than 3 months. So if you are using only rifampin, it will take 4 months. If you are using only isoniazid, it will take 6 months. So you can actually combine, or give them singly. So single rifampin 4 months, single isoniazid 6 months, combination 3 months. That's for latent. But for active, you need to introduce the 4-drug regimen. So you give the 4 of them: isoniazid, rifampicin, ethambutol, and pyrazinamide for the first 2 months. Then you now continue, with isoniazid and rifampin for 4 months under direct observation. So what are the side effects of tuberculosis drugs? So ethambutol affects the eyes, can cause like green vision, it can cause optic neuritis. Don't forget that. Optic neuritis and vision changes. Isoniazid can cause hepatitis, it can cause peripheral neuropathy, and to avoid this peripheral neuropathy, you have to administer vitamin B6. It can cause lupus, isoniazid can cause lupus, can cause peripheral neuropathy, can cause hepatitis infection, inflammation of the liver, just hepatitis, rather. And it can also be a cause of sideroblastic anemia, And don't forget, isoniazid is a CYP enzyme inhibitor. So pyrazinamide can lead to hyperuricemia, which can lead to gout. So somebody on anti-tuberculosis drug that develops gout, know that, want to ask yourself, is this person on pyrazinamide? And it can also be a cause of hepatitis, just like isoniazid. Rifampin can be an enzyme inducer. It can also change the color of the urine to like orange or red. And at the same time, it's also a cause of hepatitis. So, but it's not as severe as that of, isoniazid. So what are the other types of mycobacterial infection that is non-tuberculous? So we have other organisms that are mycobacterial organisms, but they are not Mycobacterium tuberculosis. But they are very common in people that are immunocompromised. That is one thing about them. And the most important one to discuss here is just the Mycobacterium avium complex. So that is the infection that is caused by Mycobacterium avium, and the other guys like Mycobacterium intracelluare and the likes. So just like normal Mycobacterium tuberculosis, they can cause cavitary lesions in the lungs. So the person can have fever, chest pain, hemoptysis, weight loss, and all those things. But most of the time, we are going to get it in people that have CD4 count of less than 50. So if somebody is having a CD4 count of less than 50, and the person is presenting with feature corresponding to tuberculosis, I might want to calm down to rule out Mycobacterium avium in the questions there. I'm not going to jump to Mycobacterium tuberculosis. I want to take a closer look. And what are the other presentation I'm looking out for in the question? Is there anything that talks about any disseminated, involvement, particularly involvement of the GI? So if somebody is having features of tuberculosis, and the person is having like nausea, vomiting, diarrhea, abdominal pain, I want to consider Mycobacterium avium, especially if the CD4 count is less than 50. Very, very important stuff. The other ones include Mycobacterium marinum, abscessus, ulcerans, chlorine. All these ones can cause chronic ulcers that are non-healing. So we should not worry ourselves about this lady wind damage, just like a form of Mycobacterium avium that is, common in people with some risk factors. So it's not very important. Now, people with disseminated Mycobacterium behavior, how would they present? I've said it. They have fever, weight loss, they will have diarrhea. GI symptoms, diarrhea, abdominal pain. It can suppress the bone marrow, so they can have anemia. It can affect the liver. They can have hepatosplenomegaly. So just think about GI problem, bone marrow issue, and lungs. 4, Mycobacterium avium. So the diarrhea, the anemia, the hepatosplenomegaly, lymphadenopathy, and sometimes it can even affect the adrenal gland. Don't forget, part of the cause of adrenal crisis could be like tuberculosis infection. So at the same time, it could be from involvement of Mycobacterium avium. It can, infiltrate the adrenal gland because it is highly disseminating. How do you make diagnosis? Obtain mycobacterial blood cultures. and wait for 2 to 3 weeks and see the growth. And at the same time, you can do some labs while you are waiting. So what labs do you want to order? If I were to be in the exam and I'm taking step 3, the two major labs that I should not forget would be alkaline phosphatase and GGT. These guys are very specific for Mycobacterium behavior. They are going to be elevated. ALP and GGT, involvement of the liver. Hypoalbuminemia too, involvement of the liver. And of course, we can also obtain biopsy of other potential sites that we feel that can be involved. So depending on the presentation. So we could obtain biopsy of the lungs, subjected to the AFB stain, bone marrow because of the cytopenia that they can have, intestinal biopsy because they can have, abdominal pain, nausea, vomiting, diarrhea, liver because of the hepatosplenomegaly. And we are going to be seeing the foaming macrophages with the acid-fast bacilli. How do we treat the Mycobacterium behavior? So the mainstay is to add a macrolide with ethambutol. But the first line macrolide we are going to pick in the exam is clarithromycin. Clarithromycin is the first line. If you don't see clarithromycin there, just go and pick azithromycin, combining with ethambutol. And of course, the person has to be on heart, because for somebody to be predisposed to developing Mycobacterium avium in the first instance, the person must be immunosuppressed with CD4 count less than 50. So you want to jack up that CD4 count to at least 100, by continuing this drug for 12 months. So you give them this drug for like 1 year until CD4 count is more than 100 and it is stable at that 100 or more for 6 months. We don't need to memorize this. The most important thing in our step 2 is just know the drug. Just know the drug. Very important. Now, there is no longer a need to give MAC prophylaxis if the person is on heart. Some people might forget this. Please don't forget this. Look at the question. Is this person on heart? Person is on heart. Don't give HIV. Don't give MAC prophylaxis. Don't. It's not part of the routine. If the person is on heart, then you can now give prophylaxis with azithromycin, especially if the CD4 count is less than 50. If the CD4 count is 100, don't give prophylaxis for MAC, even if the person is not on heart. The only time you want to consider it is if the person is having like CD4 count less than 50. That is usually when you want to give prophylaxis for MAC and the person is not on heart. So let us see one or two questions here. And for tuberculosis, there's a lot of questions. Let's do this. A 7-year-old boy is brought to the office as a patient. He has not seen a physician since emigrating from South Africa with his family 1 year ago. His parents report that he has been healthy except for occasional episodes of nasal discharge and sneezing while playing outside. Medical history is remarkable for infantile atopic dermatitis treated with emollient. He received all appropriate childhood vaccination, including oral polio and BCG vaccine in South Africa. His mother says that the family has had no known contact with anyone infected with tuberculosis. Vital signs are within normal limits. The lungs are clear to auscultation. The remainder of the physical examination shows no abnormality. Which of the following is the most appropriate next step in the management? What do we think? I'm not sure this question should be here.
No, no further evaluation.
Do you have a diagnosis? What's your diagnosis?
Maybe allergic rhinitis.
Yeah.
Yeah. This question should not be 18 mistake. It's a mistake. Let's look at this An 80-year-old woman is brought to the hospital due to 3 weeks of persistent fever, pleuritic chest pain, and productive cough. The patient was seen in the office 2 weeks ago for these symptoms and was given a week-long course of level due to suspected right lower lobe pneumonia. She has a history of type 2 DM and dementia and resides in a nursing home. Temperature is 38.3, blood pressure is 130, vitals are okay, oxygen saturation is 96. Examination shows decreased breath sounds at the right lower lobe. Chest imaging reveals increased right lower lobe infiltrate, right pleural effusion, and right-sided hilar adenopathy, compressing the middle lobe bronchus. Which of the following is the most likely cause of this patient condition?
Tuberculosis.
Tuberculosis, why?
The age and she's living in a nursing home.
Yes. Nursing home.
Yeah, with right-sided effusions. And right-sided hilar adenopathy.
Right-sided hilar adenopathy with infiltrate everywhere in the right. So, and again, that cough has been present for 3 weeks. Chronic cough. So, don't you evaluate for tuberculosis. All right. Let us see. I think I have one here. Let me see here. A 36-year-old woman comes to the office for a tuberculin skin test prior to volunteering at daughter's school, which is required by the state law. The patient lives in southern US and she feels well and she has never been tested for TB. The patient has no EU contact and no underlying medical condition. She was born in the US. She's not a healthcare worker and she has not been incarcerated. 2 days after intradermal injection of Mycobacterium tuberculosis (PPD), there is a 12 mm induration at the injection site. What's the best next step in the management of these patients? Anybody?
No additional intervention.
No additional. Why?
It's a healthy person with no risk factors for TB.
Exactly. Good.
And the PPD is not up to 15.
Exactly. It's not up to 15. So if this thing is up to 15, what's the best next step?
Chest X-ray.
Chest X-ray. Very simple. Some people will see that 15 and they'll go and be picking isoniazid 15 and they'll be shouting that they have blasted the exam. It's as simple as that. You know what you are looking for. Once I see it positive, the best next step you can do a chest X-ray. Chest X-ray is now positive. You are saying it okay. So that means that this person likely has a active tuberculosis rather. Because if you are seeing evidence in the chest X-ray, you can say the person is having active tuberculosis. So if it's negative on chest X-ray, you can see the person is having latent tuberculosis. So that will guide your management accordingly. Very, very important. Very, very important. Some people will say that, the person is not coughing now. Why are you managing as active? Okay, when the result comes, you know why. All right. So, a 40-year-old man with AIDS comes to the physician because of 3 weeks history of intermittent fever, abdominal pain, and diarrhea. He has also had a non-productive cough and 3.6 kg weight loss in this period. He was treated for pneumocystic pneumonia 2 years ago. He has had skin lesions on his chest for 6 months. 5 weeks ago, he went on week-long hiking trip in Oregon. Medications include efavirenz, tenofovir, emtricitabine, and he says that he had like trouble adhering to his meds. Temperature is elevated, vitals are okay. Examination shows thrush on his palate with white non-scrapable plaque on the left side of the tongue. There's axillary and inguinal lymphadenopathy, multiple volaceous plaque on the chest. Crackles are heard on auscultation of the chest. Abdominal examination shows mild diffuse tenderness throughout the lower quadrant. The liver is palpated and is enlarged. No, let them say it's enlarged. It is 2 to 3 cm below the right costal margin. And the spleen is palpated 1 to 2 cm below the left costal margin. Labs is as shown below. One set of blood culture shows acid-fast organism. A PPD skin test show 4 millimeter of induration. Which of following is the most appropriate therapy for this patient condition?
Amphotericin B and itraconazole.
Why? What's our
Does this
diagnosis?
seem to be is immunocompromised and also having signs and symptoms of histoplasmosis at this point? Yeah, with all these oral lesions, hepatosplenomegaly.
Okay. Let us look at it again. So the only issue with that answer is probably maybe because I was the one reading it. If we are looking at it in the exam, we might not have picked that answer. Let me tell you why. Look at this part in the lower part. They painted this question well to fit like histoplasm, but it does not fit. Number one, the oral lesion we are looking at is oral thrush, not oral ulcers. Number one. Then,
Yeah.
if you look at the lower part, they said grows acid fast. That changes the diagnosis entirely. What do you think this is?
Yeah.
I think it's
Maybe
Mycobacterium
maybe
avium.
non-tuberculous
Yeah.
mycobacterium,
So which one particularly?
like avium.
No.
Mycobacterium avium.
Yeah.
Mycobacterium avium. So what are we going to pick as
The last option.
the last
The
option?
azithromycin.
That is it. They are further giving us this PPD, to teach your mind towards mycobacterium issue. Acid fast, mycobacterium issue. Look at the CD4 count, 44. Problem. This guy's having candidiasis, weight loss. There's now hepatosplenomegaly. There's a reason why they are giving all these examination findings. Just go and pick mycobacterium issue. Very important stuff. Okay. So, moving on to pneumocystic jirovecii. So this is also this used to be known as pneumocystic anemia. We don't need that information, but it's very common in people that have impaired cellular immunity. So there's something affecting the T cell immunity, and also maybe person having like AIDS. It's also very common in people that are on steroids, transplant patients, and the likes. So how would they present? They are going to be having features of pneumonia that is going to be like atypical. Why? There's going to be non-productive cough. So there's fever, there's dyspnea on exertion, there's non-productive cough, weight loss, impaired oxygenation, all those things like that. We are going to see it in the question. And if we do a cytology of the sputum, because the best next step is like a sputum culture to see whatever is happening there. If it's a pneumonia, you see it. You see the organism that is involved. So if we do like induced sputum and we stain it with the silver stain, we are going to be seeing like disc-shaped yeast, which is in keeping with pneumocystic pneumonia. These are the disc-shaped yeast for pneumocystic pneumonia. And if we obtain a chest X-ray, we are going to see like bilateral interstitial opacities. They're like fluffy, like ground glass opacity. There's nothing like lobar, opacity yet. There's not like maybe upper lobe. No. This is diffuse interstitial opacity. So classic for atypical organisms like pneumocystic jirovecii. Then one important test we must always order is the ABG, because you need to check PaO2. Because once you check your PaO2, you can calculate your A gradient. Anybody remember the formula that we used to calculate the P big AO2? Anybody remember that formula? Anybody remember the formula?
Is it the one of 150?
Yes.
Minus PaCO2 divided by 0.8.
0.8. It is as simple as that. It is as simple as that. So that means that once you know your PaO2 and you calculate your PaCO2 from the ABG, you will be able to calculate the A gradient. You just slot in your PaCO2 in that formula to get your P big AO2. So that you just subtract that from the small a, and get your A gradient, small a. Oh, I can't clean that. Okay, that's fine. All right. So we see like diffuse bilateral interstitial infiltrate, the ground glass opacity on this X-ray, and if you do some labs, the beta glucan is positive. Which other organism did we say beta glucan is going to be positive in them? Anybody remembers? beta glucan. What does it stand for? What is it classic for?
Is it histo?
You can see it in histo. So it's majorly in fungal infection.
Yeah,
Beta-D glucan.
shower.
So, but we mentioned it under aspergillosis. It was when we were talking about invasive aspergillosis that we mentioned the beta-D glucan. So once you are seeing beta-D glucan being positive, you know that they're trying to tell me that this is likely to be a fungal problem. So I work with that. Then LDH is going to be elevated because of lung destruction. How do you treat? So just give them high dose Septrin for 21. We don't need to cram the days. Nobody's going to be asking us 5 days, 10 days in that step 2. Trust me, nobody. It's a drug. Once you know the drug, you're okay. But if we want to be moving stuff, we can be saying 21 days. Even step 3, you will need to be putting days. So we're going to be learning all those ones in resident. There's a lot of information to put in our head rather than now complicating the whole thing with this. So just know high dose Septrin, and um if it's very severe, you can give it IV, but if it's mild to moderate, you can give it orally. So mild to moderate disease, so these are the alternative treatments. Ideally, the mainstay, mild, moderate, severe is Septrin. The mainstay of treating hemocytic urethritis, mild, moderate, severe Septrin. If it's mild to moderate, you can give it orally. If it's severe, you can give it intravenously. But if you want to use some alternative treatment, it now depends on the degree. If it's mild to moderate, you can give trimethoprim with Dapsone. So if you look at Septrin is trimethoprim with a sulfur drug, which is sulfamethoxazole. So I can replace it with another sulfur drug, which is Dapsone. What other condition did we say we use Dapsone to treat?
Leprosy.
Leprosy. So Dapsone, this is PD deficiency. You want to rule that out before you start Dapsone. Dapsone is also very common to cause what blood disease? Anybody knows?
Mixed hemoglobinemia.
Yeah, people are ready.
Yes.
People are ready. So then PC, primaquine plus clindamycin. Primaquine plus clindamycin. You can also use it for the mild to moderate. But for severe, you can give pentamidine or PC. So those are the alternative treatment, but most likely in the exam is going to be Septrin that's going to be there. Well, if you don't see Septrin there, look for PC, and if it's very severe, look for pentamidine. So PC can work for both mild, moderate, severe. Like mild, moderate, severe, you can use PC, you can use Septrin. Mild, moderate, severe, Septrin or PC. But for severe, those are the ones you have to use, like pentamidine. Now, there's another combination that you need to look out for, and that is to evaluate if you are going to be needing a prednisolone taper. If you are going to be giving steroid and taper it down later. And what are those things that would, like give you a hint that you are going to need to add steroid? You just quickly look at the PCO2 in the question. What did the I said PCO2, PaO2. That's the partial pressure of oxygen in the blood. Is it less than 70? If it's less than 70, anything you are choosing that answer, make sure it includes prednisolone. So either you are seeing PaO2 of less than 70 or you are seeing A gradient of more than 35. So A gradient of 35 or more, PaO2 of 70 or less, hard pred to whatever drug you are giving. Very, very important stuff. So that's to reduce the inflammation and mortality. So I have a question here. So a 37-year-old woman comes to the physician because of 2 weeks history of generalized fatigue and malaise. During this period, she has had a non-productive cough with low-grade fever. And over the past 6 months, she had a 13 kg weight loss and intermittent episode of watery diarrhea. She has generalized anxiety disorder with hypothyroidism. She has a severe allergy to sulfur drugs. Okay. She's sexually active with 3 male partner and uses condom inconsistently. She has smoked 1 pack of cigarette daily for 20 years and she drinks 2 or 3 beers daily. She does not use any illicit drugs. Current medication includes paroxetine level and etonogestrel. So pulse oximetry on room shows oxygen saturation on 94. Examination of lungs show bilateral crackles and rhonchi. She has white plaque on the lateral sphere of the tongue that cannot be scraped off. HIV testing is positive. X-ray shows symmetrical diffuse interstitial infiltrate. Which of the following is the most appropriate pharmacologic treatment for this patient? Anybody?
B.
The person is sulfur allergy.
Yeah.
Yeah.
So B. So we cannot
Yeah.
give D. We cannot give E rather to this B. That's very correct. Okay. Sorry, I don't have that SS rule. But let us look at it. I don't know. My image doesn't say. A 25-year-old male graduate student is brought to the emergency department for respiratory distress after was found by his roommate coughing and severely short of breath. He was diagnosed with HIV 3 months ago, but not adherent with antiretroviral drug. His roommate reports that he had had a cold and had been coughing for 2 weeks. The patient is from Chile and moved to the US 5 years ago. He appears unwell and is unable to speak in full sentence. Temperature is 38.2. Vitals are very deranged. Blood pressure is low. Oxygen saturation is 86. No oral thrush. Patient is placed on oxygen. There's elevated lactate. CD4 count is 98. Beta glucan is elevated. Arterial glass shows this. The X-ray of the chest is shown. Empiric antibiotic treatment is started. The most appropriate next step in management is what? What's going to be our likely diagnosis here? Even if we don't have X-ray.
PCP.
PCP.
PCP, why? Why?
The increased LDH, increased beta glucan.
Exactly. Thank you very much, doctor. Thank you so much. So this is a fungal problem. HIV somebody, with all this kind of presentation, just think of what was it called? PCP. So although if we check the X-ray, we are going to see the bilateral, ground glass opacity. So what are we going to do for this person?
Add prednisone.
We're going to hide.
Prophylaxis.
So why?
PO2 is less than 70.
PO2 is less than 70. So this one is 60. Yeah, that's correct. Because they told us that empiric antibiotic has been started. So the only thing we want to add is spread. So moving on to anthrax. Anthrax is very common. We know that it's very common in people that have exposure to animals. So what is the organism that causes anthrax? That is a Bacillus anthracis. So it's a gram-positive rod, which is spore forming. So people that play with animals, veterinarians, farmers, individuals that handle animal wool, the hides and hair of animals can get exposed to anthrax. So it's used as a biological weapon. So they take all the spores, they spray it to the enemies. So once the enemies inhale it, they develop pulmonary anthrax and they start dying. So because the inhalation from which is the pulmonary one is the most deadly. So mind you, there's no person-to-person spread. You can't spread it by contacting somebody. No. So what are the three spectrum? Cutaneous, pulmonary, and GI. So the cutaneous occurs when there's probably like a skin break or injury, and the spores get entry, like they gain entry into that injury. They release all these little factors and the edema factor, and there's going to be like changes in the skin. So it's going to start like a purple, that's going to be pruritic, evolve into an ulcer with a necrotic center, and the surrounding edge are going to be edematous. So we see something like this eschar with edematous border. This is classic for anthrax, cutaneous anthrax. Central necrotic skin lesion with edematous border. Think about anthrax. And the reason why there is edema is because of the what? The edema factor, which is the CMP in the spore. So that edema factor retains water, making the edges enlarged or swollen. So what about the inhalation now? So the spores, when they get inhaled into the lungs, they start damaging the endothelial lining of the vessels of the lungs. So the person is going to be having hemorrhage, pouring out blood everywhere. So the person is going to be having chest pain, fever, hypoxia, then bleeding into the lungs, which is going to lead to pleural effusion, and of course, the mediastinum is going to be widening. They will not have any pulmonary infiltrate because there is no organism that is infiltrating. What is causing the entire problem is the spores. So there is no pulmonary infiltrate, but the mediastinum is going to widen because of the bleeding. So for the GI, so once somebody ingests a spore, they are going to have like bleeding from the GI. So abdominal pain, bloody diarrhea, nausea, vomiting, and even hematochezia. That's like, passing out bloody stool. So bloody stool, abdominal pain, dysphagia can be the features of GI anthrax. But the first two are the commonest one, inhalational and the cutaneous. So you can make your diagnosis by doing like culture isolation, just culture it and grow, or do a PCR test. Sometimes you might need a chest X-ray, especially for the inhalational disease, so that you can see the widening metastasoma as well as the hemorrhagic pleural effusions that they have. How do you treat? So just give DC, Doxy, or Cipro, any one of them. Doxy or Cipro, that's what we use, to treat it. And if somebody get exposed to it, but the person is not yet symptomatic, you can give prophylaxis with Cipro. So always remember Cipro for anthrax. Okay. A 34-year-old man who is an infantry soldier comes to the office because of 4-day history of fever, headache, myalgia, and a lesion on his face. He first noticed a blister on his right cheek, which gradually progressed to a dark sore. He denies any recent insect bite, rodent exposure, animal bite, or scratches, but he scratched his face on the ground during a combat exercise. So 1 week ago, he returned from a 1-year deployment in Afghanistan, and the patient medical history is unremarkable. He appears ill and fatigued. Temperature is 38.3. Physical examination shows 2 cm painless cutaneous ulcer over the right cheek that is surrounded by an edematous halo. The center of the lesion is necrotic. He has multiple abrasions on his face and elbow. A cervical lymphadenopathy. The remainder of the examination shows no abnormality. Which of the following is most likely diagnosis?
Cutaneous anthrax.
Xenos anthrax.
Tetanus anthrax. Okay, so moving on to acute pharyngitis, and the commonest cause of acute pharyngitis is just viral. Most of the time, it's self-limiting, but sometimes it could have some bacterial origin, maybe from gas, which is our group A strep, which is strep pyogen, or it could also follow other bacteria like Neisseria or even Corynebacterium diphtheria. I want to say it here today. Neisseria can be a cause of pharyngitis. So Corynebacterium mycoplasma pneumonia can also be a cause of pharyngitis. And of course, all the viruses, rhino, corona, adeno, herpes, influenza, HIV, they can all cause pharyngitis. So in acute HIV, pharyngitis could be like one of the early presentation. So early antibiotic treatment for streptococcal pharyngitis can prevent rheumatic fever, but not prevent nephritis. So don't forget that. If somebody is having streptococcal pharyngitis and we are starting the antibiotics, they could ask us in our exam. So what is that going to protect against? They'll put rheumatic fever there, they'll put growing nephritis. People will be confused. So the best thing to pick there is rheumatic fever and not please 1 minute, please. Okay. Yeah. So what's the history going to be like? Somebody with streptococcal pharyngitis. So they can have fever, they can have sore throat, pharyngeal erythema, exudate lymphadenopathy, soft palate, petechial rash, and of course, maculopapular rash. So we usually use the center criteria, which I'm going to show us shortly. We don't need to really cram, anything there. But usually they have like exudate in the tonsils. They have adenopathy, the cervical node. There is fever, but there's no cough. There's no cough, and of course they can have a rash. So once you see all those ones, fever, no cough, sore throat with tonsillar exudate, cervical lymphadenopathy, and a rash, think about group A strep causing that pharyngitis. So, but what are the factors that are not supportive for streptococcal pharyngitis? That is likely that the stuff is coming from other things. So once you see coryza, so somebody having coryza with like runny nose and all those things, hoarseness of voice, rhinorrhea, think about viral problems. Cough. So strep pyogenes doesn't cause cough. Once you see cough, think about something else. Conjunctivitis, think about measles. Stomatitis, think about herpes. Ulcerative lesions, think about herpes. GI problems, think about other things. It could be Legionella, it could be measles, corona, and the likes. How do we make diagnosis of group A strep pharyngitis? Usually it's clinical, if it ticks all the boxes of the center criteria. But in sometimes you might put ourselves in this, intermediate state, unequivocal. So we might need to do other further tests to separate it. So, and such next test will be like doing the rapid group A streptococcal antigen test. So if this is negative and we still have a very high index of suspicion, we can now proceed to do a throat culture. So what is this modified CENTOR criteria? So the acronym is CENTOR, CENTOR. So C for can't cough, E for tonsillar exudate, N for node, cervical adenopathy, the T for temperature greater than 38.3, and O, R for young or old. So usually you give it to the young. So if you are between 3 to 14, give them 1 point. If you are between 15 to 45, 0 points. If you are more than 45, I remove 1 mark. So I don't expect somebody that is more than 45 to be having group A strep. It's not very common in them. So that's why it's involved removing 1 extra mark if somebody is more than 45 years. But the common age is between 3 to 14. So you give them 1 mark. So how do you treat according to the algorithm? So if you calculate it and the person is getting a value of 4 to 5, you give empiric antibiotics like penicillin syrup. If the person is allergic to penicillin, you can give azithromycin. And if the person is having a score of 2 to 3, that is not up to 4 to 5. So that's like you are not still sure. So you can confirm by doing your rapid antigen test. So that's if it's between 2 to 3. So if antigen test is positive, go and give your penicillin like that. But if antigen test is still negative and you're thinking, person has gas, let me confirm, you now do a throat culture. So whatever your throat culture says, that's what you are going to follow. If it's positive, treat. If it's negative, do nothing. But if somebody is having a score of 0 to 1, do not do anything. Just give symptomatic treatment. We have talked about this penicillin. Someone that is resistant or cannot use penicillin, give them azithromycin or amoxicillin. Encourage taking like liberal fluid intake, rest, antipyretics for the fever, and saltwater gargle to reduce inflammation. So what are the complications of pharyngitis? Especially the group A strep pharyngitis. So it can cause non-suppurative and suppurative complications. So for the non-suppurative, think about the immune-mediated, all those autoimmune ones like acute rheumatic fever and post-septical glomerulonephritis. And we have said it that the only one that antibiotic can protect against here is what? Acute rheumatic fever cannot protect against post-septical glomerulitis. If post-septical glomerulitis will happen, it will happen. And most of the time, post-septical glomerulonephritis usually occur if the person has skin lesion, like impetigo. When we're talking about it in Dharma, you remember, it doesn't typically follow the throat one, but it follows more of the skin one. So for the suppurative complication where there will be pus, think about cervical lymphadenitis, mastoiditis, inflammation of mastoid bone, sinusitis, otitis media, retropharyngeal abscess, peritonsillar abscess, Thrombophlebitis of the jugular vein, which is very rare, we call that Lemierre syndrome, caused by Fusobacterial necrophorum. So Fusobacterial necrophorum can cause thrombophlebitis of the jugular vein, which is one of the complications of pharyngitis. Now, we need to shed a little more light about retropharyngeal abscess. And how the patient is going to present is that they are going to tell us that the patient is having, very serious neck pain. The person cannot open the mouth. So they are going to tell us that the person is having, let me just read what it is so that I don't miss anything. So features of tonsillitis, like sore throat, we have said, trismus, they cannot open their mouth. There's going to be neck asymmetry because there's a part of the neck where the abscess is located at. So that area is going to appear thicker. So, lateral swelling of the posterior pharyngeal wall because at the back of the pharynx. The neck is going to be deviated to one angle, torticollis. There's going to be cervical lymphadenopathy, very, very important. They can tell us that person is having like hot potato voice. The person is going to be talking as if there's hot yam in his mouth. Person cannot extend the neck, difficulty swallowing, dysphagia, painful swallowing, odynophagia. All this presentation like that, think about retropharyngeal abscess. Now, to make our diagnosis, they could tell us that they've done a lateral neck x-ray. And what they want to look at there is that they want to see if the pre-vertebral space is widened more than the corresponding vertebral body, especially the level of the see-through. So let me show us what I'm talking about. So you have to do the x-ray in the lateral so that you can see the view in anterior-posterior direction. So that makes it much more easier to appreciate that that swelling. So if you look at this x-ray now, so this is the one for so this is a lateral x-ray that's showing us anterior-posterior dimension, anterior-posterior view, and we can see that this part looks thicker than the corresponding vertebrae. So you can easily say that this person is likely having like a retropharyngeal abscess. To further now nail your diagnosis, if the person is stable and not having respiratory distress at that point, confusion or symptoms of like respiratory compromise, you can go further to do CT scan with contrast, and that would help you to be able to separate if what you have here is a collection like an abscess or what is happening here is cellulitis. Cellulitis can be happening here. So your CT scan is going to help you with that, and you can immediately go in to do a surgical drainage and place the person on broad spectrum intravenous antibiotics like ampicillin sulbactam. So that's that about retropharyngeal abscess you don't want to forget. So then we also have peritonsillar abscess. So this one is very common. People that are younger, they are very much younger than retropharyngeal abscess. And another thing you have to look out for here is that they can have similar presentation: trismus, sore throat, difficulty opening the mouth, odynophagia. Everything is going to be the same. But one of the things that you would use to know is that they will tell us that the uvula is deviated. So once you see uvular deviation, know that what you are dealing with is peritonsillar abscess. Uvular deviation is as simple as it is. It can save you a lot of headache. Once you see it, just go and pick peritonsillar abscess. So you also need to drain the abscess in this person and give them broad spectrum antibiotics. So we have talked about it, the hot potato boils, intestinal enlargement, uvular deviation. That's what you need. So just drain, and give antibiotics. Now, one of the serious complications of retropharyngeal abscess that is untreated is what? Acute necrotizing mediastinitis. So the way it is that the pharynx is kind of continuous downwards with the posterior mediastinum of the chest. So if this is mediastinum, so the pharynx is continuous like that. So it passes through some fascia. We have different fascia of the neck. The neck anatomy is very crazy. But there are some fascia here, we call the halar fascia and all those other fascia. So between that halar fascia, there's what we call the danger space. So the infection in the throat here, the retropharyngeal abscess can easily travel downwards through that halar space, danger zone, to move downwards into the mediastinum. So by the time it gets to the mediastinum, it can cause some bad pleural effusion. it can cause serious mediastinitis. And the person is going to be having like chest pain, difficulty in breathing, fever, and all those things, even with pericardial or pleural effusion. So you want to be very careful that the retropharyngeal abscess doesn't get complicated with acute necrotizing mediastinitis. So that's why you have to go in and drain quickly and place the person on antibiotics. If we are not very fast, this is a potential cause of death in them. So, yeah. So that's that. Let's see if we can get one or two questions here to. Hello?
Yeah. At what point do they give steroid in the management of this tonsillitis?
Do they
Is
give
there a role
steroid?
of yeah?
I don't think so. I don't think you use steroid here. So if it's because most of them is bacterial, like just give you antibiotic. Do they use steroid? Anybody has an idea? I don't know if they use steroid,
Oh,
but I know that
okay.
they just give penicillin. If it's streptococcal, it's penicillin. So I don't know if there's any indication for steroid here.
Oh, okay.
Yeah. So so let's see if we can see one or two questions, to drive home the point. So this is a 58-year-old man who comes to the emergency department because of 2-day history of dysphagia, swelling in the neck and lower jaw. Let me see. Okay, no, this one should not be here. We'll come back to this. A 7-year-old boy. Yeah. Let me see. I'm sorry, just a minute. Okay, I think we should be able to answer this. A 7-year-old boy is brought to the physician because of 3 days history of fever, headache, headache, sore throat that is worse when swallowing. He has not had any runny nose or cough. He had similar problem 1 year ago, for which he was prescribed amoxicillin, but afterwards developed a skin rash, facial swelling, and dyspnea, and he switched to a different medication. His immunizations are up to date. He's 75th percentile for height and 50th percentile for weight. Temperature is 38.9. Pulse is 136, respiration is 28. Examination of the oral cavity shows a bright red tongue with prominent papillae, a red uvula, and an enlarged right tonsil covered by whitish membrane. Deep cervical lymph node are enlarged and tender. Which of the following is the most appropriate next step in the treatment of this patient? Anybody?
Penicillin V.
The person is allergic to penicillin.
Oh, he's allergic. Sorry.
Yeah,
Septra.
Wait. Okay. Yeah, I'm seeing it.
So if you can, there was a drug I mentioned. If you can't give penicillin, you give another.
Azithromycin.
Azithromycin. So which one are we going to be picking here?
Clarithromycin.
Clarithromycin.
Please let us pay attention to all those subtle things. Very important. Let's do the last question. A 7-year-old boy is brought to the physician for evaluation of his sore throat for the past 2 days. During this period, he has had intermittent nausea and vomited twice. The patient has no cough, hoarseness, or rhinorrhea. He had similar symptoms at the age of 5 that resolved spontaneously. He's healthy. Temperature is 37.4. Pulse is 85. Blood pressure is 108. Head and neck shows erythematous pharynx with grayish exudate over the palantar tonsils. There's no lymphadenopathy. A rapid antigen detection test for group A strep is negative. Which of one is the most appropriate in the management of this patient? Anybody?
Any other option?
Which other option are you looking for? You can say it.
How about A? Measurement of this
No,
strapline with
no,
old tighter.
no, no. It's a tempting option, but remember, when we're talking about the algorithm, we did not mention the title, so don't do it.
Oh, okay.
Reassurance and
Reassurance.
So here now, it's likely going to be reassurance. But if there's no reassurance, what other option do we think they can put?
symptomatic treatment.
Mhm. Okay, let us calculate this person's center score. What are we getting?
2.
2. Why is it 2? Why is it 2?
Age 3 to 14.
Age 3 to 14. What's the second one?
Exudate. Tonsillar
Exudate. Exudate. Is it
Mhm.
coughing? Is it coughing? No
Can't
cough.
cough.
That's
Okay,
3.
no cough. Oh, that's
So
3.
that's 3. Okay. So lymphadenopathy is not there. So this guy is having 3. Fine. Now we said 2 to 3. What do we do? 2 to 3. What do we do?
Rapid antigen
Rapid
test.
Exact
antigen test.
antigen.
So they did rapid antigen test for this person and it is negative. So what else are we supposed to do ideally?
Throat culture.
Throat culture.
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 Very simple. You are already setting question for you already even know the way to think. Ideally, we are just looking for throat culture, but it's not here. So just assume that they want to take our mind off it. Then we can pick reassurance and follow up. So the question can come in different ways. So that is that. All right. So moving on to Ludwig angina, and Ludwig angina is just a big name for infection of the submandibular and the sublingual space. So if this is a tongue, if this is a tongue, we have a space in beneath the tongue that we call the submandibular and the sublingual space. So this area can get infected, and when they get infected, they become swollen. That area becomes woody hard, and in a way they will elevate this tongue and push the tongue backwards. Anybody knows what will happen when the tongue is moving backwards? Anybody? What happens to somebody when the tongue falls backwards?
Obstruct the
There's
The
going to
air.
be
entrance
hallway.
obstruction.
There's going to
Yeah.
be airway obstruction. So that's why for people with Ludwig angina, we need to act very, very fast. Please, 1 minute, my people. I'm coming. 1 minute. 1 minute. Okay. So for people with Ludwig angina, we have to act very fast so that we can secure that airway. Very, very important. So yeah. So now we have talked about pathophysiology. There's inflammation of the throat. So I said throat, the submandibular and the sublingual space, elevating the tongue, and it falls backward. So usually the inciting condition is when somebody have injury, in the mouth, usually like in the third molar and the likes, they can cause a spread of infection downwards like that from that area. It can also occur in people with, poor dental hygiene, trauma, instrumentation, and all those things. So the cause is usually polymicrobial. So all those strep pneumos, staph aureus, anaerobic organisms, they are all implicated in Ludwig angina. So what you want to do is giving prompt. And now there's not going to be lymphadenopathy. There is no lymphadenopathy here. No lymphadenopathy. Don't forget, in this guy, retropharyngeal abscess and peritonsillar abscess, there's lymphadenopathy. But here, there is no lymphadenopathy. All what is accumulating here is just like abscess. So, give your giving your surgical drainage to remove the abscess, putting your intravenous antibiotics, and if there's a need to secure the airway, probably the tongue is already falling back, everything's getting obstructed, you've gotten breathing, quickly go and put in your intubation so that you can secure that airway. So ABCD of resuscitation is very important here too. So I don't want to put in too much story there. just give broad spectrum antibiotics, anaerobic cover, include anaerobic cover. So you can use clindamycin, you can use amoxiclav. Just give anaerobic cover for it. So let's look at a way, people can present with that and what to do. So this is a 13-year-old girl who was brought to the emergency department with a 10-day history of fever, sore throat that was acutely worsened over the past 2 days. Her sore throat is worse on the right side. She has difficulty swallowing and opening her mouth because of pain. She also noticed that a change in the quality of her voice over the last day, and temperature is 38.2. Pulse oximetry on room air shows an oxygen saturation of 98. Examination shows anterior cervical lymphadenopathy. Oropharyngeal examination shows erythematostosis and swelling along with a white exudate on the right tonsillar pillar. Uvula is deviated to the left. So we already know the answer. So what are we going to do for this patient? Anybody?
If it's a peritonsillar abscess, I want to incise and drain.
Yeah.
So
And then
what
give
option?
antibiotics.
So what option are we picking?
That would be option C.
C.
See,
Incision and draining.
without antibiotics.
Yeah, there is option
What
D there.
about
Also,
D?
you have to
It was
continue with antibiotic
antibiotics.
therapy in addition to the incision and
Exactly.
drainage.
So we drain, I will give antibiotics. We don't stop our drainage. I did not say we should stop our drainage. Incise and
Oh yeah,
give,
D.
Yes, I didn't see the
antibiotics.
option.
Very, very important. Okay. All right. So let's look at this. A 50-year-old man is brought into the emergency department with progressive retrosternal chest pain and shortness of breath for 1 day. The pain is severe, worsens with inspiration, and radiates to the neck. He had had a sore throat and neck pain for the past 2 days. He remained bedbound during this time and had a poor appetite. 1 week ago, he underwent upper endoscopy for PUD. He had type 2DM PUD. Okay, blah, 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 blah. Temperature is 39.1, pulse is 108, blood pressure is 88. Lungs are clear to auscultation, abdomen is soft. Oropharyngeal examination is limited because the patient is unable to open his mouth due to pain. Hematocrit is 13,000. The patient is intubated in the emergency department and appropriate treatment is started. Chest X-ray showed widened mediastinum. Which of following is the most likely treatment that will have prevented this patient condition? Anybody have an idea of what this patient is having? What we have said?
Necrotizing mediastinitis.
Mediastinitis. So what is the cause of the necrotizing mediastinitis in this patient? What do we think?
Dental procedure that he had on the background of diabetes mellitus.
Yes. So what is that one going to likely cause? What did we say is the risk factor for developing this necrotizing mediastinitis?
Acute retropharyngeal
Abscess, exactly. When they are putting it there, you scope, that's where they have, go and cause trauma to the pharynx. And there's retropharyngeal abscess. So that now became complicated with mediastinitis. Very simple. So, what are we going to do? What should have been done to prevent the stuff in this patient? Anybody?
Antibiotics.
Which one? There's 2 antibiotics here. Which one? Which one did we see?
Ampicillin,
Ampicillin,
B.
sulbactam. Ampicillin, sulbactam. No catch. So that's the way to look at all those things. Just have to know what you are looking out for, and you'll be able to figure your way out. So acute lymphadenitis is just unilateral, inflammation of the lymph node, commonly caused by Staph aureus or Staph pyogenes. They typically affect the sublingual lymph node. Just give antibiotics if you feel any feature of abscess. So that's that about lymphadenitis. So sinusitis, we have the acute and the chronic. So sinusitis just means inflammation of the paranasal sinuses. And the commonest sinus affected is the maxillary. So most of the time, the cause of acute sinusitis is what? Viruses and sometimes some bacteria like strep pneumo, H. influenza, and catarrhal. So that is what we call shame. So shim. Shim is the cause of acute sinusitis. Shim is also the cause of acute otitis media. Strep pneumo, H. influenza, Moraxella catarrhalis. So acute sinusitis is just sinusitis lasting less than 1 month. Once it's more than 3 months, chronic sinusitis. If it's in between, you can call it subacute sinusitis. So what are the things that we are going to see that's going to increase suspicion for bacteria? Because it is the bacterial one that we are worried about. If it's viral, the person is just going to be having runny nose, facial pain, headache. It doesn't go beyond that. It's going to subside before like 2 weeks, or even like before 10 days is gone. But for the bacterial one, they persist for more than 10 days. The person having the fever, they're having the facial pain, they're having purulent nasal discharge. So the purulent nasal discharge separates the bacteria, the shim, from the viral. And of course, because of the nasal discharge, they can have hypnosmia and nose smell. They cannot smell, For the chronic sinusitis one, it's when it passes for more than 3 months. So there must be something ongoing in that place that is driving that chronic inflammatory process. This person having like allergic rhinitis, is having Wegener's granulomatosis. Does this person have cystic fibrosis, even asthma? These are things that you want to rule out in the history, for acute sinusitis. So what are the potential complications of sinusitis? Very common question. Meningitis, it can go up from the sinuses, like this in the nose. They can go up to the brain, meningitis. They can also go to the frontal bone to cause frontal bone osteomyelitis. They can also go to the brain and cause cavernous sinus thrombosis. Cavernous sinus thrombosis. I know from neurology, Dr. They will have gone to town and tell us how that kind of person will present. We also need to remember the way we manage them. Don't forget your vancomycin, vancomycin, metronidazole, and all those. Vancomycin, vancomycin, ceftriaxone, rather, to treat, your CST, cavernous sinus thrombosis. Don't forget the treatment. Don't forget the presentation. Very important. They can ask you. So, sinusitis can also lead to abscess formation. So, watch out for the complication. It can also progress to optic cellulitis. We know the way optic cellulitis presents. We have talked about electric angina now. Now somebody with sinusitis, how would they present? With the fever, the facial pain, the headache, the purulent nasal discharge. If it's bacteria, we have talked about all these things. There's going to be high fever. You do your labs, leukocytosis. There's going to be purulent nasal discharge. So somebody having high fever, leukocytosis with purulent nasal discharge, just going to pick bacterial sinusitis. Any one of the shim, any one of the shim. But the commonest one from the shim is going to be strep pneumo. That's the best to pick. So sometimes sinusitis can be caused by fungal. Microbiology then, we used to talk about it in step 1. People, infection from rhizopus and mucor. They can have chronic sinusitis that's going to be necrotic. So you see like necrotic, lesions in the face, in someone that's diabetic or someone that is immunocompromised, affecting the face, the vision, and everything like that. Necrotic tissue. Just think about fungal sinusitis. When you are seeing also nasal symptoms too, nasal congestion, discharge, necrotic tissue on the face, think about, mucor and rhizopus fungal as a cause of that sinusitis. So it's very common in people that are neutropenic, people that have immunosuppression, or people with DM. So these guys now, they are very good candidate for amphotericin B. And what? After giving an amphotericin, what do we even do? There's even something we do before we give amphotericin B. What do we do? Anybody?
You debride.
You debride. You look at debridement and you give amphotericin B. So sinusitis is a clinical diagnosis. You don't need to be doing any imaging. But if you want to do imaging because you are not sure, you can do like transillumination, just shine light and see. So there's going to be opacification. There's going to be opacification of the sinuses in that area. And the area with the sinusitis too on CT is going to appear opaque. So all this part now, this is part where we have the, sinusitis. So this is left maxillary sinus. You can see the opacity here. So this is hair filling the sinus. It should be hair that is there, but this guy is not containing hair. This is containing fluid, exudate. So, that's where the problem is, not here. This is where the problem is. So how do you treat? If it is viral, there won't be any high fever, there won't be any leukocytosis, and there won't be prolonged discharge. So that kind of condition, just say it's going to be self-limiting, give symptomatic treatment. Oh, you're having like discharge a bit, but it's not prevalent. Okay, take the congestant, oxymetazoline. If you're having like if it's maybe due to like maybe the person's having like maybe underlying allergic stuff, you can give antihistamine just to reduce the inflammatory process. You can irrigate it by doing nasal saline lavage, and if it's very painful, you can give an analgesic. So for the bacterial sinusitis, don't forget for the bacterial sinusitis, you want to give antibiotics, and the major antibiotic you use is just amoxiclav. Even if somebody is having otitis media, give amoxicillin. If amoxicillin doesn't work, give amoxiclav. That's the way it works. So here too, you can give amoxiclav, to treat the sinusitis. If you can't give that, you can give the other ones like clarithromycin or azithromycin, just like we do for people with acute pharyngitis. So give clarithromycin or azithromycin after you have considered your amoxicillin, or sometimes you can also give them Septrin or even a fluoroquinolone too. How many do you want to know? Let's just amoxiclav, the macrolide, Septrin. That's okay. So for the chronic sinusitis, just look for the underlying cause. What's the underlying cause of this thing, and try to treat it. So sometimes you might need to do surgery. Probably there's a nasal septum that is occluding that nasal cavity that you cannot have discharge from the nose. Everything just occluded and just congested in that area. So you might need to go and do surgery. For people with underlying problem like maybe cystic fibrosis, try to manage that cystic fibrosis. If is having asthma, try to correct that asthma, and you might give all these other things like steroids, decongestants, and antihistamine, just like you have done initially. So it might be helpful. Symptomatic relief, usually. But this might not take care of the underlying cause. If you are giving histamine, decongestant, or steroid, it's just for symptomatic treatment. You have to look for the underlying cause to treat, before you can eradicate the chronic sinusitis. So don't forget, sometimes you might even need to go in and do surgery. So, moving on to hemoptysis. So let us try to look at hemoptysis quickly. So hemoptysis is just when you have exfiltration of blood from the lower respiratory tract, and the bleeding is coming from beneath the vocal cords. So now, what we need to know here, so bleeding from the pulmonary artery is low pressure. Bleeding from the bronchial artery is high pressure. Now, what is massive hemoptysis? Massive hemoptysis is when somebody is bleeding like more than like 100 mils, or like more than 600 over 24 hours. So if you are like bleeding out 100 mils, or over 24 hours you are bleeding out 600, that is massive, with hemodynamic compromise, obviously. So what are the etiology? Just look at the airway. This is the airway. Look at problem with the lungs. Airway leads to the lungs, kind of. Look at problems around the vessels of the lungs, and external factors like coagulation disorders. So for the airway, so it could be bronchitis, chronic bronchitis. They can have hemoptysis. People with bronchiectasis, don't forget, that one is even classic. Bronchiectasis. Hemoptysis is like one of the number one thing. Lung neoplasia, they can have hemoptysis. It could be foreign body that is there, hemoptysis. So for the parenchyma, the lung tissue itself. So is this person having TB involving the lung? Is this person having some vasculitis? Like somebody with Wegener's, somebody with good posture. Don't forget, somebody with Behçet disease, vasculitis, very strong candidate for having hemoptysis. Behçet disease, good posture syndrome, and what? And Wegener's granulomatosis. So parenchyma of the lungs, TB, and all this vasculitis, for the vessels surrounding the lungs, they can also be the source of the bleeding. Is this person having like, AVM in the vessels, arteriovenous malformation that's bleeding? Does this person have pulmonary embolism? And when did we say that if somebody having a pulmonary embolism that's not having hemoptysis, what do we say have happened to that lung? Anybody remembers? Anybody remember what I said in already? If somebody with PE is already having hemoptysis, I said it that day. So if somebody having PE, now having hemoptysis, you can be rest assured that the lung has already become infected. The area of that lung is already infected. So it could also come from bleeding disorders. Think about any bleeding disorder you can think of. It can cause, hemoptysis. So what do you do? Just try to make sure you rule out any life-threatening hemoptysis, that this person is hemodynamically stable, because that will change your management totally. So the first thing is to look, is this person hemodynamically stable? Do I need to go and do ABCD approach? Airway management, blood, breathing rather, circulatory, and blah, blah, blah. If the person is stable, okay, you might now need to order chest X-ray. If the person is having, lung cancer, bronchiectasis, parenchymal problem like TB, all those ones will be quickly picked with your chest X-ray. You can have further have a deeper look by ordering a CT that could give you like a closer look at whatever you are dealing with. And you want to do your ancillary investigation like complete blood count, coagulation study for the bleeding disorders, urinalysis. Anybody knows why you want to do urinalysis? Can anybody know that? Does anybody have an idea from the causes we have mentioned why you might want
To
to
rule out
consider?
histoplasmosis.
Okay. No. Histoplasmosis can never be ruled out with urinalysis. Okay. Well, if we are saying that urinalysis is like analysis of the urine, because urinalysis is not entirely about that you just dipping stick. Even if you culture you like, it can be like a form of urinalysis, but histoplasmosis, no, not really. What else?
Is it Wegener's granulomatosis?
Yeah, Wegener's granulomatosis, exactly. What about
Good pastures.
good pastures? Exactly. All those
Good
ones will be picked. The material will be picked, and similar to the rheumatologic workup. So if we are trying to rule out Wegener's, what rheumatologic workup are we going to do?
Bianca.
Bianca.
Wegener's. Wegener's. Is it Bianca? Bianca. I know that that's why I asked. I know that most people is always P that usually comes to mind. That's the only one we always say. So but it's actually PR3. Yeah?
But Wegener's can also, instead of Cianca, they have this, is it PR3 something?
Yeah, that's what I'm saying. So proteinase 3,
Yeah.
antibody or your Cianca. So they go together. You do them. So it's just like MPO Pianca, myeloperoxidase Pianca, PR3 Cianca. So you treat the massive hemoptysis, try to secure the airway. If it's massive, bleeding more than 100 mils, or they have bled more than 600 mils in 24 hours, want to secure the airway quickly, placing endotracheal tube, secure their airway, transfuse blood, immediately for hemodynamic stabilization. Why you now go ahead and do bronchoscopic intervention. So you insert the first line is usually flexible bronchoscope to quickly be able to navigate your way through, to see. But sometimes it might be difficult that you might need to use a rigid bronchoscope. I don't think that is necessary. You just say bronchoscopy, go there and go and embolize. That's the mainstay, usually. So let's follow this algorithm. Somebody comes in bleeding 100 mils per hour or like 150 mils in 24 hours. Usually it should be like 600, but let's work with 150. Or the person is having like respiratory distress, hemodynamic instability. This guy is not all right. So we have to go and follow the ABCD approach. So quickly intubate, give oxygen if it's necessary, connect to mechanical ventilator. What's it called? Give blood, fluids, crystalloid. If blood is available, quickly push blood there. Then insert our tube to do a bronchoscopy. And once we do our bronchoscopy, and we can see the bleeding area, we can embolize immediately. If it's something that might need to get resected, you do your resection immediately. So for people that are much more stable, so you can start with X-ray. Don't forget, you can do the labs in which you are doing the coagulation studies, you are doing the blood count, rheumatologic workup, and all the analysis. Then do your X-ray, follow your X-ray with the chest CT to look at like maybe lung cancer or whatever. It could be bronchiectasis, lung cancer. You can see all those ones with the CT. Then if there's anything that is suspicious there that you might need to arrest, you can now go and do your bronchoscopy. If there's normal image that you cannot see anything there, just go and do your bronchoscopy and have a closer look. But if you can see anything there, maybe lung cancer, bronchiectasis, now manage accordingly. So you can just give, if bronchiectasis, give the steroid, the antibiotics, what's it called? They call it like chest physiotherapy and the likes. If it's lung cancer, if it's something that can be responsive to chemo, small cell, give chemo, and the person moves on with his life. So that's that about evaluation of hemoptysis. Let me see if I have any question here. Yeah, I think I have one question. So if a 58-year-old man comes to the emergency department because of multiple episodes of coughing blood for the past 2 hours, he says that he has coughed approximately half a cup of bright red blood each time, and he had progressively worsened shortness of breath on exertion and productive cough with occasionally blood tinged sputum for the past 6 months. He has a history of hypertension, COPD. He drinks 2 to 3 beers every evening. He smoked 1 pack of cigarette daily for the past 30 years. Medication include amlodipine, tiotropium, albuterol. Temperature is 37.2. Blood pressure is 97/63. Oxygen saturation is 89. He's anxious and cachectic. His condition of the lungs show decreased breath sound bilaterally. Patient coughs or copious amounts of blood. Hemoglobin is 11.5. Leukocyte is 8,800. Platelet count is 160,000. Coagulation parameters are within normal limits. Serum studies and analysis shows no abnormality. He is intubated and mechanically ventilated. Infusion of 0.9% saline is begun. An X-ray of the chest show hyperinflation of the lung field and a 2 cm nodule on the right lower lobe. In addition to placing this patient on the lateral decubitus position, which of one is the best next step in the management? Anybody?
CT scan.
CT scan.
Why?
Bronchoscope.
Why are we going to do CT scan? No? Please, my people. No, there's no
Bronchoscope.
problem. There's no problem. I just want to know, like, why are we doing the CT scan? This guy is bleeding. This guy is having hemodynamic instability. Blood pressure is
Unstable.
97.
Now,
That's the only answer. That's the reason why you cannot do a CT scan urgently now. He's actively bleeding. He's having like hemodynamic instability. Look at the oxygen saturation. I saw it somewhere.
89.
89. He's having like decreased breath sound. That guy is going. So quickly, because of the hemodynamic, just go and do bronchoscopy and arrest that bleeding before you now start looking at something else. So there's something I forgot to mention. So once they come in and they are actively bleeding, you want to place them on lateral decubitus. So you decide that the bleeding that's where you try to make them lie on. So what you are trying to do is lung isolation. So let us picture that there's somebody like this now. Okay, I can't write here. So this person comes to the emergency and is bleeding. So this is the chest. So what we do is that this is the part that the bleeding is. So this person is going to lie on this part so that gravity is going to be making the blood to pool here and will spare this lung. Because if this person is standing up, it might spread to the other lung. So in this form, it is only this lung that will be congested, and this lung will be normal, so that the person can still be breathing with this lung. So this is called like lung sparing position. Then you quickly also give some agent that can arrest bleeding, can just help, like tranexamic acid, while you now proceed to now go and do the bronchoscopy after you have done ABCDE of management. So very, very important. So before you give anybody CT imaging, always look for hemodynamic instability. Once somebody is unstable, never pick CT. Never. It will be wrong. So, pleural effusion. So let us quickly do pleural effusion. And then afterwards, you just take a break and we come back and round it up. So, pleural effusion is very simple. We all know pleural effusion, and this is just accumulation of fluid in the pleural space. It's as simple as that. So, and okay, we don't have any image here that shows what pleural effusion looks like. So let's just quickly remind ourselves. I know that we all know it, but just to quickly remind ourselves, pleural effusion. You know what it looks like. X-ray. See the meniscal sign, all those things. So this is the meniscal sign here. And we can see the opacity with the meniscal sign. So this is pleural effusion here. So it could be of two different types, transudative or exudative. Transudative just means that the problem is change in the pulmonary capillary wedge pressure or the oncotic pressure. So if the pulmonary capillary wedge pressure, which is a form of hydrostatic pressure, is increased, there's going to be transudative effusion. So it means that in this vessel now, the hydrostatic pressure that acts in this vessel like this, in this direction, is high. So maybe this person has heart failure and fluid is pooling in the vessel. They'll push blood out into the lungs, and there's going to be pleural effusion, transudative type. Or maybe the proteins that are here that are supposed to be keeping fluid inside the vessel are low, probably because the person has a liver problem or the person has nephrotic disease. Fluid is going to leave again. So transudative. Exudative is anything that now damage this endothelial lining. It's not due to pressure issue. It's not due to oncotic. It's just that this vessel damage has occurred from inflammation, from trauma, or from sepsis or anything. Increased vascular permeability, allowing fluid to escape into the tissues. That is exudative. Now, what are the criteria that needs to be met before you can quickly classify? Just quickly check. You want to take a sample of your pleural protein, request pleural protein, request serum protein, request pleural LDH and serum LDH. Then you compare them. So if the ratio of the pleural protein to serum protein is more than 0.5, it means that the pleural protein is more than 50% of the serum protein. That's a problem. So, or if the pleural LDH is the pleural rate over the serum LDH is more than 0.6, that's another problem too. Or if the pleural LDH is more than 2/3 of the serum LDH. So if any one of these criteria is met, you can say that this person has an exudative effusion. So pleural protein over serum protein, is it more than 0.5? Pleural LDH over serum LDH, is it more than 0.6? This pleural LDH you are measuring, is it more than 2/3 of the upper limit of the serum LDH? So if they tell us that the serum LDH is 10 to 20, and we get our own pleural, this is serum LDH. This is serum LDH that we measured. So that is the normal serum LDH. Now, if we now measure the person's pleural LDH and we are getting value of 8, so 2/3 should be like 66%. So 8 is 8 over upper limit of the normal. So this is upper limit of normal here is going to be what? 20, right? Right? So I cannot use it. Let me say like let me use like 16. So 16 over 20, what would I give yourself? Yeah, I don't know. What's 16 over? So if you calculate 16 over 20, it's going to be more than. So 16 over 20 should be like 80% or so.
80%.
Yeah. So, that is going to be more than 2/3 of the upper limit of normal, because, that is upper limit of normal is 60 something percent. So this is 80%. So that's more. So any one of that, once any one of that has been fulfilled, you can say that this person is having exudative effusion. So if none of the criteria is met, that is transudative effusion. So now you can categorize transudative into the one that's actually with increased hydrostatic pressure, like commonly heart failure, CKD because of the edema that they have, and early pulmonary embolism. Late pulmonary embolism is exudative. Early pulmonary embolism is transudative. Then anything that causes reduction in the oncotic pressure, like we said, liver cirrhosis or nephrotic, and any other thing is going to be exudative. I would not advise us to be learning intrathoracic and no, but trust me, nobody is going to be asking us right-sided, left-sided. No need. Just like any other thing, is going to be exudative. So for transudative, just look for the underlying cause. Heart failure, treat it. CKD, treat it. PE, treat it. But for the exudative, you need to do further workup. Once you are seeing exudative, you need to go and do further workup to look for the underlying cause, because there's a wide range of potential causes. So somebody comes to us and we want to say that, okay, this person has pleural effusion. What are we going to find? They're going to have difficulty in breathing. They're going to have pleuritic chest pain. They can have cough, depending on the cause. If we percuss that area, because of the fluid there, it's going to be dull. Breath sound is going to be reduced over that area. So pleural frictional rub might be present, depending on the etiology. So this is just a table showing the potential examination findings for different lung pathologies. So if you have somebody that has pneumonia with lung consolidation, if you percuss, it will be dull. If there's fluid there, it will be dull. If there's air, pneumothorax is going to be hyperresonant. If you do our tactile femometers, so tactile femometers will have high conduction if it's consolidation. Consolidated tissue can easily transmit sounds. So tactile femometer is high, but in other lung pathologies, it will be low. It is only in lung consolidation that tactile femometers is increased. We should not forget that. Don't forget that. It's as simple as it is. Some people can forget. So breath sound is going to be bronchial. This kind of had like a very high pitch, kind of, and the other ones it's going to be like reduced or absent. Voice transmission is very similar to tactile femometers and this breath sound. So there's going to be egophony or bronchophony, more like high pitch sounds, kind of. So E is going to sound at A. E, A. So here like has high pitch compared to E. So that's egophony. Y in pleural effusion and pneumothorax, voice transmission is going to be reduced or low. So for crackles, we are going to hear the crackles in lung consolidation. In other ones, it is absent. So, what's the best initial test? So somebody comes in now with this. Of course, the best initial, and we do examination and we find this. Dull, reduce tactile femometers, reduce breath sound, reduce vocal femometers, no crackles. The best next step now to do X-ray. Do X-ray to see whatever is happening in that lung. Why are we percussing dull tissue? Why is tactile femometers reduced? So if we do the X-ray, we are going to see what I showed us initially. There's going to be blunting of the costophrenic angle with the meniscal sign. So after that, the best next step to do is to order thoracocentesis. So you want to take a sample. You want to take a sample of that collection in that area, and you send that for study. You now quickly do light criteria. With the sample, we quickly measure light criteria. So whatever stuff we are getting, we can classify. It's likely to be transudative or exudative. So because we obtain that fluid and we are going to measure the pleural protein and the pleural LDH to classify into that. So this is a table again. This is a table again. Now, part of the analysis that we do is going to be like the pH of that pleural fluid. So most of the time, this pH can give us a quick idea of what we are working with during the question. In the exam, if you know this, it will help you too. Although I'm not saying we should rely on it too, but it's very helpful. So people with transudative, they usually have a pH more than 7.4. Once you are seeing a pH of less than 7.4, have a high index of suspicion that's going to be exudative. 7.4 is the cutoff. Once it's more than 7.4, it's likely to be transudative. Once it's less than 7.4, it's likely to be exudative. So, what's it called? So yeah, so exudative meet the light criteria that we have talked about. So once you see that what you are seeing is exudative, you now need to go and be doing other workup, and these are the list of things you want to order. So you want to request for pleural fluid, glucose, amylase, cytology. You want to see the cells that are there. You want to count the number of white blood cells that are there. You want to culture that pleural fluid, gram stain it, subject it to AFB test, tuberculosis antigen, rheumatoid factor, check your CCP and ANA because it could be SLE, it could be rheumatoid, it could be from rheumatoid arthritis, it could be from tuberculosis, it could be from cancer. So you rule out all those things by doing all this workup. So, so what are the potential, but if it's transudative, most of the time you don't need to be doing workup like this. So just treat the underlying cause because you will have picked the underlying cause. The person is going to be having feature of heart failure. So just manage the heart failure to go. If the person is having CKD, manage the CKD to go. So most of the time when you see pleural effusion too that is bilateral, most of the time too is going to be transudative from like heart failure or CKD. Most of the time it's bilateral. So most of the time when it's bilateral, they don't usually do thoracocentesis most of the time. So what are the complications of pleural effusion? So we can have parapneumonic effusion with empyema. That's one of it. And this is said to occur when somebody have a pleural effusion from pneumonia, lung abscess, or bronchiectasis. So somebody with pneumonia or lung abscess or bronchiectasis that now develops effusion with empyema, that is parapneumonic effusion or empyema. So what are the features of different types of parapneumonic effusion? So we have uncomplicated parapneumonic effusion, we have complicated parapneumonic effusion, and we have empyema. So the difference between uncomplicated parapneumonic effusion and parapneumonic effusion is just that there's no, it's just fluid. Bacteria is not there. So in that kind of person, you don't need to put in a chest tube because there's no much bacteria there. So that's why we say that it's uncomplicated. So it's just fluid moving into the pleural space because of the pneumonia. Bacteria is not usually there. So it can appear clear or cloudy. If you measure the pH, it's going to be what? More than what? It's going to be less than what? Ideally, because it's parapneumonic effusion. It's going to be less than what? Ideally. Anybody?
7.4.
Yes.
7.4.
It's going to be less than 7.4, but it will still be greater than 7.2. Very important. It's going to be less than 7.4 because it's exudative. From pneumonia, from lung abscess, and bronchiectasis. So it's definitely going to be exudative. But the pH is going to be more than 7.2. Glucose is going to be reduced on normal. LDHO is going to, so this one is just following normal light criteria. So if you now do a pleural fluid gram stain and culture, it will be negative because there's no bacteria there. Just give antibiotics to treat the pneumonia. That's all. For complicated, there's bacteria there, but the bacteria is not sufficient enough to be picked by gram stain. So, and because of the fact that bacteria is there, it's going to be cloudy because there's a form of inflammation happening there. And pH2 is going to be less than 7.2. So anytime I do pleural fluid analysis and I'm getting a pH of 7.2 or 7.1, I know that number one, this is less than 7.4. It is exudative. But it's now even less than 7.2. This is likely going to be like a complicated parapneumonic effusion. Very important. Very, very important. So in that kind of person, automatically they will benefit from both antibiotics and chest tube placement. For empyema, there's a lot of pus in that pleural fluid. A lot of bacteria, they have colonized it. So if you look at it, it's going to be purulent. pH is going to be less than 7.2. Glucose is going to be low because the bacteria is going to be feeding on the glucose inflammation, on the glucose everything. If you stain it, you culture bacteria. It's going to be positive. So put in a chest tube and put in, some antibiotics. Another complication of effusion is recurrence. So in this kind of people, you want to do a pleurodesis. Just go and fuse those pleural space together so that there's no space for, collection again. So complicated parapneumonic effusion and empyema, they necessitate chest tube drainage. But uncomplicated, don't put in chest tube, just give antibiotics alone. Do you have any question? Any question for me? Let's solve this question, then we'll go for a break. Okay. A 4-year-old boy is brought to the clinic due to fever for past 5 days. He has also had cough productive of yellow-green mucus. The patient had pneumonia a year ago that required a hospitalization for hypoxia. Currently, he takes no meds other than acetaminophen as needed for fever. The patient has received all the vaccination except for annual influenza vaccine. The family originates from Peru but was born in the US and has not traveled out of the country. Temperature is 38.9, blood pressure is low. Oximetry is 99%. Physical examination shows a young child with more mucous membrane, rails, and decreased breath sound over the left lower lung with comfortable work of breathing. X-ray shows an opacity over the left lower lung with minimal layering of fluid on decubitus film. Which of following is the most appropriate next step in management? There's layering of the fluid. So what are we going to do for this patient?
Yes, is it loculated pleural effusion? Test tube placement.
It's not loculated. They said minimal layering.
Minimal layering. Okay.
CT scan of the chest.
Did you talk about CT
Antibiotic.
scan throughout today?
About
No,
it.
did not talk about CT scan
Antibiotics.
today. They've done X-ray
Yeah.
already. They've seen the pleural effusion.
Oral antibiotics.
We want to start oral antibiotics
We have to
before
give
doing the
oral.
chest.
Yes.
Yeah,
What if
before doing the chest.
it could just be uncomplicated,
Yeah.
effusion. So you might not need to put in a chest tube. There's minimal layering. If it's very complicated, you'll be seeing like loculations, like pulse. I'm supposed to also mention that there's going to be loculation, just like somebody mentioned. So that could be a pointer to the fact that there's something much more severe going on there. But this is just like small layering. It's not even very plenty. The effusion is not that much. It's small, and there's like some layering there. So, ideally the best next step is to like do thoracocentesis and do your pleural fluid analysis, but we don't have that here. So the best thing here is just to give antibiotics because we are sure that this is an infection. He's having productive cough, he's having fever, he's not having pleural effusion. The surest one that he must get is antibiotics. That one is constant to all the three. So we now decide later, are you going to get in a chest tube or not, depending on the severity and if it's complicated or not. So let's look at this. A 61-year-old man comes to the emergency department because of shortness of breath and rest-sided chest pain for 3 days. The pain is sharp and worsening with deep inspiration. He has also had a fever and a cough productive of sputum for 5 days. Temperature is 38.1. Pulse is 85. Respiration is 22. Blood pressure is 132. Physical examination shows dullness to percussion at the base of the right lung. Breath sound are diminished over the right middle and lower lobes. An X-ray of the chest shows blunting of the right costophrenic angle. Pleural fluid obtained via diagnostic thoracocentesis shows a pH of 7.1 and a glucose concentration of 55. In addition to broad spectrum antibiotics, which of following is the most appropriate next step in the management?
Chest tube,
Chest
please.
tube placement.
So why?
Tube.
Why do we think we have to put in a chest tube here?
Because the pH is less than
It looks like
7.
complicated parapneumonic effusion.
Yes, this is more like pneumonic effusion is complicated because the pH is 7.1. Yeah. Okay, please let us go for a break. I will come back in 15 minutes exactly. Thank you. Okay, welcome back everyone. So we are moving on to pneumothorax, and this is just talking about collection of hair in the pleural space. So which can, at the end of the day, compress on the lung, leading to lung collapse. There are three types of pneumothorax. We have the primary spontaneous pneumothorax and the secondary pneumothorax and the tension pneumothorax. So the way to just look at it is there are two major forms, the spontaneous one and the secondary one. So the spontaneous or the primary one, they have no cause. The secondary one, there's an underlying cause. So any one of these two can get complicated and become, a tension pneumothorax. That's just a way to look at it. So the primary or the spontaneous pneumothorax occur when you just have like rupture of the subpleural blebs, which is very common in people that are very tall, very thin, and young. So young and lanky people, they have a very high risk of having primary spontaneous pneumothorax without any underlying reason. So just because of their physique. So their lungs grow in a direction that allows for easy formation of this pneumothorax. Secondary pneumothorax can occur due to some underlying causes. Possibly maybe the person have some underlying COPD, there's trauma, infections like tuberculosis, pneumocystis jirovecii. Or probably the person underwent a process. So if this is a lung and this is a lining, the pleural lining the lung, this is a pleural space because it has to be like two lining. So we have the visceral lining, and the parietal lining outside. So let's imagine that this person undergoes a procedure like thoracocentesis or subclavian vein placement, and mistakenly they puncture the lung. They puncture the lung this way. So that can allow air to move from the lung parenchyma into the pleural space, leading to pneumothorax. And when this pneumothorax expands, it can compress on this lung, leading to lung collapse. So procedures like thoracocentesis, subclavian line placement, bronchoscopy can easily lead to pneumothorax, and even use of mechanical ventilation. So don't forget, if the pressure is too much, plateau pressure is too much, that stuff can expand too much and it will burst. So when the lung bursts, what's going to happen? Air is going to be released and they can track and find their way to the pleural cavity, and from there's going to be a pneumothorax. So now, tension pneumothorax now happen when you have that excessive pressure build up in the pleural space now compressing on the mediastinum, shifting the mediastinum and the other mediastinal structures to the contralateral side. So, and one of the common mediastinal structure that can be kinked would be the IVC. So SVC, IVC, they are kinked, and that would impair blood return to the heart. So if blood cannot return to the heart, the person is going to be having a form of obstructive shock, which can lead to hypotension. And because of the shift in the mediastinum, you have like structure like the trachea also shifting to that contralateral side. So if there's a tension pneumothorax on this side, everything moves to the right side because this is the left. So everything moves to the right side. The trachea moves to the right side. The what's it called? The mediastinum is shifted to the right side, and that will kink the vessels there, reducing blood return to the heart, leading to hypotension. So that's about tension pneumothorax. So it usually occurs when you have a one-way valve. So you just have something that is allowing air to move into the pleural space in a one-way direction, just like this. The air cannot leave. So if it's a one-way valve, it's going to lead to tension pneumothorax at the end of the day. It will just continuously be moving into the pleural space without leaving. So, what are the features of tension pneumothorax? So, person could have pleuritic pain, deviation of the trachea, we have talked about, hyperresonance. So because of the hair building up in that pleural space, if you percuss that area, it's going to be hyperresonant. Most of the time, it is sudden onset. Sudden onset because in breathing, with hyperresonance, dull breath sounds. Think about pneumothorax. There's going to be absent femtors, and of course, X-ray can show lung collapse because of compression of the lung. So, how would they present? Don't forget, sudden onset in the lateral pleuritic chest pain and dyspnea. This could also be PE, so it doesn't really tell us that much. They're going to have tachypnea, but with diminished breath sound. So this is not likely in someone that has PE. Here, breath sound is going to be diminished or reduced. With percuss, there's going to be hyperresonance. Tactile fremitus is reduced. And this is increased in what condition?
Consolidation.
Consolidation. So JVD2 is increased because of compression of the SVC. The SVC is compressed, so that means that there is no way the IJV, which is the internal jugular vein, would empty into the SVC. So if this SVC that is already kinked, kinking of the SVC will block IJV from emptying into it. So there's going to be internal jugular vein distension. That's another thing to look out for. So when tension in pneumothorax now setting, there's going to be tracheal deviation and hemodynamic instability. Very, very important. Hypotension and tracheal deviation, you can quickly use that to nail tension in pneumothorax. And this is very important because the approach to management differs. Don't forget, tension in pneumothorax, you don't wait for x-ray. You nail the diagnosis clinically by your examination and your history. If you obtain a chest x-ray, you are going to see visceral pleural line and of course lung retraction from the chest wall. Yeah, not everybody might be skilled enough to be able to see that. So it's not something to actually rely on. And there's going to be hyperlucency, just like we have here. You can look at this lung. So this lung is very, very lucent. It's hyperlucent. It looks very dark. It means that hair is actually accumulating here. And if you look at this part, this is a collapsed lung that's compressed on that lung and the lung has collapsed. That's the remaining that you're having of the lung. If you look at this trachea, it's already deviating to the right rather. So this is likely to be a tension pneumothorax. The best next step is just to ask, to look at the question, is there any hypotension? Once you see hypotension, immediately you want to go and needle that patient. Tension pneumothorax require needle decompression first before you now later place in chest tube. So you can see an option that will tell you needle decompression only. Some people, that's what they will pick. After you needle, you still go back and put in a chest tube. Very, very important. So for tension pneumothorax, don't forget about the presentation, immediate needle, and what? At the second intercostal space, that's where we put in the needle. And of course, we put in the chest tube later. With a small pneumothorax, less than 2 cm or 2 cm exactly, observe and give oxygen, it will reabsorb by itself. If it's large but symptomatic, please don't needle. Put in a chest tube. Very correct. Put in a chest tube. Don't needle. You only needle if the person is having a tension pneumothorax. Don't forget that. Patients who are unstable or having a recurrent pneumothorax, put in a chest tube. Very, very important. Put in a chest tube. So let me see if we have any question here. Okay. This is a 22-year-old man who comes to the emergency department due to sudden onset dyspnea 2 hours ago while watching TV. The patient dyspnea is gradually improving, but he still has a sharp right-sided chest pain that is worse with inspiration or cough. Medical history is unremarkable. The patient smokes 4 to 5 cigarettes daily and occasionally drinks alcohol. Temperature is 36.7. Blood pressure is 140. Pulse is 86. Respiration is 18. Pulse oximetry shows 98%. X-ray shows a small right apical pneumothorax. Which of following is the most appropriate management of this patient? What do we do?
Supplemental oxygen.
Supplemental oxygen, because this is a small right apical pneumothorax. It's just small. Oxygen is good. No catch. A 63-year-old man is brought to the emergency department 30 minutes after being involved in a high-speed motor vehicle collision. Is obtunded on arrival. Is intubated and mechanically ventilated. Ventilator is set at FiO2 of 60, tidal of 44, PEEP of 7. On the third day of intubation, temperature is 37.3, pulse is 91, blood pressure is 103. There are decreased breath sound over the left lung base. Cardiac examination shows no abnormality. The abdomen is soft and non-distended. At ABG is as follows. So these are the ABG results. Monitoring shows a sudden increase in the plateau airway pressure. X-ray of the chest show deepening of the costophrenic angle on the left side. Which of following is the most appropriate next step in the management? I don't know if we have the X-ray. Let me see. I don't think the question has any X-ray. I just wanted to be sure. Okay. No X-ray. All right. What do we think for this question?
Needle decompression.
Why?
I think he has tension pneumothorax.
Evidence by
Decreased breath sounds over the left lung base.
but that doesn't make it tension. You know, you are trying to prove like it's tension, not just ordinary pneumothorax. So people with ordinary pneumothorax and tension pneumothorax, both of them will have decreased breath sound. But that doesn't make it tension.
Shall we increase
Then the
the
blood
PEEP?
pressure.
But this blood pressure, is it very low?
No, it
No.
looks
If it's
okay.
less than 90 or less, like you know.
Mhm.
So and they're not telling us anything about the trachea.
The mechanical ventilation,
Increase PEEP.
So what are we going to do? Somebody said increase PEEP.
I
If we
think
increase PEEP, what
I
will
just
happen? If we increase the PEEP, what will happen to this patient? The whole alveoli will start collapsing. So what is this patient having? That's just what I'm trying to figure out. Like, let us look at everything about the mechanical ventilator. So they told us that there's a sudden increase in plateau pressure. We have done this yesterday. Plateau pressure increased suddenly. X-ray is showing deepening of the costophrenic angle. There's reduced breath sound. What do we think this person is having?
Just a
We
massive
didn't.
pneumothorax.
This person is having pneumothorax, but it's not
Yeah.
tension. It's not tension.
Mm.
So what are we going to do?
We
Maybe
insert the
check.
test tube.
We insert a chest tube. That's the answer. We don't do needle decompression because this is not tension. If it's tension, you can needle. But if just ordinary pneumothorax that is symptomatic, put in a chest tube. So that distinction is very, very important.
Excuse me, sir. Why is it on the left side? That's my confusion, though.
Yeah. I don't understand what you mean by why is it on the left.
Like the breath sound is decreased on the left side.
So that's where the pneumothorax is happening. That's where the pneumothorax is happening. So most of the time it will be unilateral. It's very rare for us to see pneumothorax happening bilaterally. So that's just telling us that it's, on that side. And again, it's in keeping. If they are telling us that breast is on the left side now, and they are telling us that X-ray is showing another thing, maybe on the right, then we'll be confused. But all the pathology is on the left. So it shows us where the problem is. So
Dr. Damahu, is the X-ray findings,
yes.
the deepening was a bit confusing to me.
Yeah. So I guess
What
that's one of
I
the features of
oh,
yes, it's one of the features of pneumothorax. There's a lot, but we cannot be learning all of those things because it's complex. They will talk about presence of the visceral line. They talk about this deepening, but to be honest, it won't get to that level in the exam. You won't need to know that kind of deep stuff to be able to pick that diagnosis. Let us look at that image. Let me see. I'm coming on. So if you look at the costophrenic angle, this is the costophrenic angle here. So it looks a little bit deeper compared to this. If you look at this one, it's like on a higher, like a lower level compared to this. I guess that's what they mean. Do you see that, doctor?
yeah. So is it synonymous with saying it's like flattening of the?
No. Flattening
Okay.
is going to be like, you see this curve.
Yeah. Mm-hmm.
Can you see this curve here? You will not see it.
Yes.
You will not see this curve again. So
Okay.
it's going to be flat. There's still a curve here.
Okay.
So this is not flattening of the diaphragm or whatever they call it. But here, the diaphragm is still kind of, the contour of the diaphragm is still maintained.
Okay.
So yes, but this one is deeper. The the costophrenic angle. This is it here. Costophrenic angle is deeper than that of this one.
Okay. Thank you.
You're welcome. So so that's that about tension pneumothorax. I've just said, what we should always pay attention to, because some people don't know that. So look at it. If it's tension, needle. If it's not tension but symptomatic, put in your chest tube. It is as simple as that. So so moving on to the pulmonary sleep disorders. The first here is obstructive sleep apnea. This one is high yield. We have to know it. So, and it's usually caused by transient obstruction of the airway leading to hypoxemia. I'm going to ask you a question later. So, etiology can be categorized to central or secondary. So, central in that is coming from the CNS, stroke. So, there's a problem in the brain that prevents the body to be able to control the airway. So, ideally, they'll be able to send signal. The brain sends signal, to control the airway, to kind of relax the muscle. If you relax these airway muscles, they are going to. So the way it works is that for you to keep the airway open, all the pharyngeal muscles that are here, that are in the. Sorry, I'm not very good with drawing all these things. I'm just trying to make an illustration. Let's just assume that these are the pharyngeal muscles here. To keep this airway open here, you need to contract these muscles. So when they contract, they give way for the airways to open. That's it. But once they are relaxed, this thing will close. So in people with stroke, there's a reduction in the transmission of impulses to all these muscles under CNS control. So it's lost. So intermittently, you can have relaxation of these muscles and it obstructs. And that will make the person now wake up. And that's what called the RERA. They try to wake up, which would, in a way, open up that airway again. Due to that, the conscious effort, to try to open up the airway. So they will now regain their breath. So people with stroke, they usually have that problem. So another condition, aside central problem, is secondary. So people with secondary cause, example, people that are obese, because this is obstructive lung apnea, sleep apnea that we're talking about. People that are obese, they are very, very predisposed to developing this thing, because they have a lot of fatty infiltration of all these muscles. So in a way, that fat narrows this area, number one, and again, weakens the muscle. You know that any muscle that is infiltrated by fat, it will affect their contractile power. They will not be able to contract well. So they will relax, which can lead to closure of that airway, leading to difficulty in breathing, which we call obstructive sleep apnea. Now, the word sleep is there because the problem typically occur during sleep. In sleep, physiologically, respiratory drive drops. So if you are still awake like this, even though somebody is having obesity and the airway muscles cannot, contract well, they are relaxed and all that, but because you are still conscious, you are trying to do some activity, that conscious effort will still keep the airway open in a way because you still have like increased respiratory drive and all those things. But if somebody is now sleeping, that respiratory drive is already dropping, all the muscles in the body, the muscle tone, especially during REM sleep, muscle tone is already dropping. We remember this from neurology. The tone of the pharyngeal muscles too is dropping. These muscles are relaxing. So that means that this airway has a very high tendency to collapse at that point, leading to obstructive sleep apnea. So what are the risk factors? Are you a male? Because they have a lot of like fatty infiltration of that area than females. Male sex, older age, obesity, very important, most important. Craniofacial abnormality, we'll get there too. Like upper airway abnormalities like adenodal hypertrophy in children. Adenoids. Adenoids are like how do I put it, like lymphatic structures in the nasopharynx, which is just on top of the airway. So if there's adenodal hypertrophy, you occlude the airway, and there's high tendency for obstructive sleep apnea. When they are sleeping, that obstruction becomes more prominent, and they can develop sleep apnea. Sedative use. Sedative use works the same way like stroke. Because of that central impulses that are dropped, because you are sedated, you cannot control the airway again. Don't forget, somebody that's having a GCS less than 8, they cannot control the airway. Why? Because that CNS control is gone. Someone that's having stroke, CNS control is gone. Someone that is on sedatives, alcohol, benzo, CNS control is gone. So that airway can easily collapse. Now, smoking too is a risk factor, because of the airway changes with smokers. Now, what are the cardinal features that you don't want to forget for obstructive sleep apnea? They're going to tell us in the question that the person is going to be having intermittent cessation of breath during sleeping, and the person is going to be waking up intermittently to try to catch his or her breath. They are going to be snoring. Now, to make the diagnosis, there is a machine that we use that we call the polysomnograph. And what that polysomnograph is going to do is to measure some respiratory pattern during sleep. We connect the machine to the person sleeps, we get the results from the machine. So what the machine is going to show us would be episode of apneas, episode of hypopneas, and episode of RERAS, which is respiratory effort related arousal. Let me see if I have the definition. So I have the definitions here. We don't need it. There's no way they will paint the question that we don't know that this OSA happening. But what is apnea? Apnea is just when somebody have complete or near complete cessation of inspiratory airflow for 10 seconds or more. So somebody that fails to get in here into his airway, it's not as if the person is not ventilating. No. The person is actually still trying to make some auscultatory effort. The diaphragm is trying its best. The abdomen is moving up and down, but air is not entering. So somebody with a complete or a near complete, that is, you are saying more than 90% cessation of airflow for more than 10 seconds, you call that apnea. If there's a reduction by 30% for 10 seconds, you call that hypopnea, because that is not as severe as apnea of 90%. For respiratory effort related arousal, there's arousal from sleep due to increased respiratory effort. So the person is having apnea or hypopnea, and because of that, the person just wakes up to try to regain the breath. That is respiratory effort related arousal. All these three things can be captured by the machine, by the polysomnograph. So we marry everything together, especially the apneic or the hypopnea episode. We add them together, and we use some values, to make our diagnosis. I'm going to show us, slightly. Now, shortly rather. Now, people with obstructive sleep apnea, because they are not getting enough sleep, they are not refreshed. By the time they wake up in the morning, they are tired, they are fatigued. By the time they wake up in the morning, they still want to sleep because the sleep has been interrupted so many times. And because we find that they are tired, they are fatigued, they still want to sleep, it affects their concentration and cognition. They cannot concentrate in class. They're always having headaches. And what are the signs we are going to see in the question that is going to tell us that this person is having like disturbed sleep? They'll be telling us that the person is snoring due to the obstruction of the airway. When air cannot pass through that airway, they'll be snoring because of the resistance. Because of RERA, they'll have gasping episode. They wake up trying to catch their breath. That's gasping. They'll feel choked and they'll be restless. So once you see this in the question stem, think about the possibility for obstructive sleep apnea. Why are you gasping? Why are you choking when you are sleeping? What thing happen now? Why are you snoring? Possibility that we are dealing with obstructive sleep apnea. Now, there is a survey that we use to assess the risk of somebody developing obstructive sleep apnea, and that's a stop bank. The S for snoring, the T for tiredness, the O for observed cessation in breathing, the P for blood pressure, they are usually hypertensive, the B for BMI greater than 35, the A for age, don't forget older age, they are at risk. So age more than 50 at risk. Neck circumference of greater than 40, too much mass in that neck. So, narrowing the airway. So anybody with neck circumference of more than 40 is a problem. And of course, the last one is a G, male gender. So any three positive items, immediately go and order a sleep study, polysomnography. They should do sleep testing because they have a very high risk of developing obstructive sleep apnea. So once you are a male, you already have one already standby. You are just looking for two more. If you are now a male, you are now obese, more than 50 years, you might have to do, and you are having all these symptoms, you might have to go and do a sleep study immediately. So what are the complications? There's an increased risk of cardiovascular morbidity. Why? Because don't forget, somebody that is choking, that is restless, that's having apnea, there's going to be hypoxemia. So, and don't forget, hypoxemia in the pulmonary vasculature causes pulmonary vasoconstriction. So there's pulmonary arterial hypertension. Hypoxemia increases sympathetic drive. So they're going to be having hypertension, systemic, not pulmonary now, systemic hypertension. So they have both systemic and pulmonary arterial hypertension. So these things can accumulate to even increase risk for CAD. Because of the remodeling in the heart from the hypertension, they can have arrhythmia, can have heart failure. Because of the hypoxemia, release of erythropoietin, they can have polycythemia. Polycythemia is a very good risk factor. In addition to hypertension, they are very good risk factor for what? For stroke. There's an increased risk of insulin resistance and type 2 DM. Anybody knows why? Anybody knows why from what we have said? Insulin resistance and type 2 DM. What is the common thing between these two guys? Type 2 DM and insulin resistance. What's common to them?
Obesity.
Obesity is one of the risk factors for obstructive sleep apnea, right? Yes.
Mhm.
So that is
Yeah.
why people with OSA can have insulin resistance and type 2 DM. They have a very high risk for motor vehicle collisions and impaired alertness because they are not sleeping. Poor cognition, poor concentration, so they can have accidents a lot of time. Best initial test. We look at that kind of presentation. The best next test is just go and order a polysomnography, sleep study. And of course, you are going to assess for the apnea-hypopnea index, in which you would calculate the total number of apnea and the hypopnea episodes divided by total hours of sleep. So if you are getting an index of more than 5 or equal to 5 plus symptoms, which is the snoring, gasping, choking, headache, somnolence in the morning, all those symptoms like that, and you have AHI value of 5 or more, you can make your diagnosis. If the person doesn't have symptoms, but you are the carrier of the symptoms, but the person has 15, you don't even have to wait for symptoms before you make your diagnosis already. Very important. So the index 15 or more, straight up. If it's 5, but the person has symptoms, it is good enough to make diagnosis. What do you do afterwards? Or having identified the problem, what do we do? Are you obese? Go and lose weight. Most of the time, 90% of them will be obese, so tell them to go and lose weight. Are you a smoker? Stop smoking. Then afterwards, you place them on the CPAP. They have to be carrying that CPAP every time when they are sleeping. They have to sleep with the CPAP. So what the CPAP is going to do is to deliver a positive pressure ventilation, a positive pressure, which would keep the airway open during inspiration and expiration. But the problem with CPAP is that it delivers only a single constant continuous pressure, unlike the BiPAP. So BiPAP delivers not a single continuous pressure. It delivers, two pressures, but they are different, intensity. It delivers more pressure during inspiration. So the inspiratory pressure is more than the expiratory pressure. Unlike CPAP, that is only one single pressure. So if it's delivering 10, it's 10 both phases. But in BiPAP, it will be more in inspiration than expiration. So which is good, because if you have more pressure delivered during inspiration, it will help you in ventilation, so that you can take in air. You know that we take in air, oxygen, during the inspiratory. So there's a high chance that oxygen will be able to, get into that lung. So that's why BiPAP usually assists with ventilation. So if somebody have issue with ventilation, place them on a BiPAP. It can help them. So if you have done CPAP, it's not working, promote weight loss is not working, tell them to stop smoking, it's not working, you can now use other appliances. You can use some horror appliances. They fit in all those appliances in the mouth to kind of recalibrate the airway and keep it open. They're just like appliances they apply to the mouth to keep the airway opened during sleep. They can do hypoglossal nerve stimulation. So the idea is just to stimulate the tongue, so that when they are obstructed, airway is getting narrow, you just contract that tongue. The tongue would kind of help to open the airway and it also move forward. So that's hypoglossal nerve stimulation. You can also do maxillomandibular advancement. So in some people, it's because the way the mandible and the maxilla are arranged, that's why the airway is kind of disfigured. So they try to like recalibrate that, appearance of the mouth, and they bring in the maxilla and the mandible, to relieve the obstruction. So last resort is just go and put in a tracheostomy, but you'll never get to this. Trust me, this is debilitating. So it won't get to that. So moving on to obesity hypoventilation syndrome, there are two different things. People with obesity hypoventilation syndrome, I just want us to picture them that we already said it, that during sleep, the tone of the airway is already dropping because of the REM sleep. Respiratory drive is already even reducing already. So there's even a background increased tendency for airway obstruction. Now the person is not having like obesity again. Now what obesity is going to do is that obesity is going to infiltrate the muscles of the chest. And when there's too much fat infiltration of the muscles of the chest, they will not be able to perform their excretory action. They will not be able to contract, relax, and all those things. So it can impair ventilation. So it means that when they are sleeping, when respiratory drive is already dropping, the obesity is now going to even now worsen that ventilation, because the muscles will not be able to contract again. So they have more problem too at night. But their own will also persist to the day. That's the difference between obesity hypoventilation syndrome and obstructive sleep apnea. Because their own problem is not related to night only. There's already fat in the chest wall that is not allowing them contract well. So both night and day, they are having hypoventilation. So because of the fact that they don't get good sleep, when they wake up in the morning, they are hypersomnolent, just like in OSA. Of course, there's going to be obesity. How do you make your diagnosis? First, there's some associations. People that develop obesity hypoventilation syndrome, most of them will have developed obstructive sleep apnea with it. So 90% of patients with OHS will have had OSA. And anybody with this kind of situation, the management differs. While the other 10%, they are going to have sleep-related hypoventilation, and I have a definition for that. And this is defined as somebody that has desaturation, which is SpO2 less than 88% for 5 minutes, with a rise in PCO2 during sleep. That's what you call sleep-related hypoventilation. Don't forget, the mainstay to make diagnosis of hypoventilation, what parameter are we looking at? We look at PaCO2. We should not forget. That's what we usually say. How you can know that somebody is hyperventilating is to look at your PaCO2. So it's going to be increased, and the saturation of the oxygen too is going to drop. Don't forget what I said about the fact that in obesity hypoventilation syndrome, the problem is during the day and night, it's constant. It's there. So it is a diagnosis of exclusion. You must have ruled out all the other causes of hypoventilation, Guillain-Barré, myasthenia gravis, everything. Rule out everything before you now narrow your diagnosis down to this. Now, what are the requirements that must be met by the patient? They must have a BMI greater than 30. Obesity, that's constant. You must be there. They should have a awake alveolar hypoventilation. What do we mean? That is, when they wake up in the morning, you check that PaCO2 is going to be more than 45. That is awake alveolar hypoventilation. So you cannot call this OSA again, because this guy is now having it in the day. So this is going to be OHS. And of course, you must have ruled out other causes of hypercapnia and hypoventilation. So what do you do? Because most of them are obese, promote weight loss and give a non-invasive positive pressure support. Now, which one are you going to choose? If you see that in the question, you are seeing features of OSA and OHS, put in a CPAP because of the OSA. But if CPAP fails, you can now proceed to do BiPAP. But for people with OHS with hypoventilation, you need to support ventilation. You need to give something that can help with ventilation. And it's only BiPAP that can do that. It is as simple as that. If that doesn't work, one reduce that with bariatric surgery and tracheostomy at the end. So let's look at one or two questions here. A 48-year-old man is evaluated for progressively worsening dyspnea and exertion for several months. The patient had frequent awakening at night due to choking sensation and feels tired all the time, limiting his physical activity. He does not take alcohol. Blood pressure is 166, 100. BMI is 48. JVP is difficult to assess due to neck fats. Heart sounds are distant with no murmurs. Bilateral breath sounds are normal with no crackles or wheeze. There's trace bilateral pidgin edema present. X-ray shows poor inspiratory effort but clear lung fields. Which of the following additional finding is most likely present in this patient?
And the decreased BMI to bicarbonates.
Why?
Because it's not breathing out the CO2 well, and CO2 is accumulating, and the body is trying to compensate for the respiratory acidosis.
Yeah. Nice. Very good analysis. So that's it. So the person is not breathing out PCO2. So PCO2 accumulates. There's a respiratory acidosis. And the way the body can compensate for that is by reabsorbing, bicarbonate in the kidneys. So, that's a reduced chloride due to bicarbonate. And you know that if you are taking bicarbonate, you must not be taking chloride again, because both of them, they are negative, they're anions. So you have one anion already, discard the other one. So that is why, because of the bicarbonate retention, we have to discard chloride. So if you look at the other ones, you can rule them out. They will not be there. So anemia due to low erythropoietin. What do we expect for erythropoietin? It should be increased. It should have polycythemia. Decreased PCO2 due to persistent hypoxia. No. PCO2 is rather increased. Decreased sodium due to increase. This has nothing to do with antidiuretic hormone, and increased BMI due to volume depression. This makes no sense. Okay. Let's see. There's a lot here. I think they're simple. They're very simple. Okay. A 52-year-old man is brought to the office by his wife. According to her, he repeatedly wakes up at night and seems to be choking, but falls back asleep quickly. The patient reports fatigue and often falls asleep while reading books or watching TV. He has childhood asthma that requires inhalers. Other medical conditions include type 2 DM, hypertension, hyperlipidemia. Medications include metformin, gliptin, statin, lisinopril. The person doesn't use tobacco and drinks alcohol only on weekends. Blood pressure is 150, pulse is 80, BMI is 34, no JVD. Lungs are clear to auscultation. There is a grade 2/4 apical holosystolic murmur. There's no galomegaly. There's mild bilateral pitting edema. What is the most likely cause of this patient's symptoms? Anybody?
D.
Yeah,
D.
auricularis.
Yeah. Very good one. Okay, let's move on. Let's move on to rhinitis. So rhinitis is just inflammation of the nasal mucosa. So it's characterized by rhinorrhea. They're always having like watery discharge from the nose, nasal congestion, sneezing, and itching. Most forms involve inflammation except one, and that's the vasomotor. So that's the one that occurs due to like temperature changes and all those things. Vasomotor rhinitis. So that one doesn't involve any form of inflammation. We can classify it into allergic or the non-allergic. So the allergic one is due to type 1 hypersensitivity. IgE mediated type 1 hypersensitivity of the nasal mucosa. And so it may be associated with other atopic disease, like maybe asthma or eczema, like atopic dermatitis, because it is an allergic process. So it can be classified into intermittent, seasonal, persistent, or perennial. But trust me, we don't need this. Nobody's going to be asking us the classification. How do we make the diagnosis clinical? If they tell us that somebody is having like all these symptoms at a particular season, when they get exposed to something, when they go and play football, or when they, just like that question we saw the other time, is likely to be like allergic, maybe rhinitis or something. When they get exposed to something, or when they develop it at the particular time, it resolves again, comes out like that, or when they eat something, just know that this is allergic rhinitis. We can do skin prick test, introducing common allergy to the skin to observe for hypersensitivity reaction. If we measure the IgE level, is going to be increased. So we can do the serum radioallergosorbent test to identify IgE antibody to the specific allergen. Trust me, never pick this as your answer. It will be wrong. Trust me. Just you can go and test it. It will be wrong. So clinical diagnosis, you can see the labs. IgE will be elevated. That's good enough for your diagnosis. So any of the allergen that is identified, maybe after this skin prick testing, just avoid that allergen. The medication that are usually given are the non-sedating antihistamines, and it's given orally. Very, very important. So we give oral non-sedating antihistamine like loratadine, cetirizine, and fexofenadine. All these ones are non-sedating. They are second generation. And in addition to that, you can add intranasal steroid. So you give the steroid, you put it in the nose because of side effect of steroid. You cannot just be using oral steroid. So you can just, use the steroid intranasally while you give the antihistamine orally, to suppress the inflammation. And people that have concomitant asthma, you can give montelukast. Immunotherapy is a very good approach in which you expose them to the allergen and you desensitize them in the process. But most of the time, you try all these things first before you go to immunotherapy. So for the non-allergic rhinitis, there are different other things. It could include irritants, exposure to smoke. It's when they get exposed to smoke that they start developing that stuff. Or maybe when they go to work because they are exposed to some certain chemicals or pollutants. Those are the irritant rhinitis. Then we have the vasomotor one, which is due to increased blood flow to the nasal mucosa. Why? Because of temperature changes or because they are exposed to dry hair or irritant odors. That's when they just that thing happens to people a lot. You see some people when they get exposed to something, their nose start, becoming watery. That's vasomotor rhinitis. Gustatory, when we taste some sweet pepper soup, that can cause, rhinorrhea. That's gustatory rhinitis from pepper soup. Then drug-induced. So people that get exposed to some certain drugs, antihypertensive, NSAIDs, cocaine, and the like. So we don't need to cram anything here. We don't need to cram it. It's not very likely. But if you want to know it, you can know it. But I don't have any acronym for it. Hormonal rhinitis. So this one occurs during pregnancy and is due to exposure to some of those hormones like estrogen and progesterone. So it's very common in people that use OCP2. But after pregnancy, it drops. The senile rhinitis is one that occurs in elderly people due to atrophy of the mucosal, of the nasal cavity. Because when there's atrophy of the mucosal, all those glands that are producing moisture, they will have gone. So that's kind of, in a way, drives some inflammatory process that leads to the rhinitis. So senile, hormonal, drug-induced, gustatory, vasomotor, and irritant. So what do you do? Just do a workup for allergic. How do you do the workup? Take the history, do the labs. Are you seeing elevated IgE or not? You can do the skin prick test. Just rule out allergic rhinitis. The treatment is usually driven by the symptom. Just do like symptomatic management. Giving intranasal steroid, just like we are using in allergic rhinitis too. Put it in intranasal steroids there. You can use because we can also use antihistamine too. We can put in intranasal antihistamine, but don't forget for allergic, you use oral, second generation antihistamine. So here too, you can use antihistamine, but it should be in intranasal. We can use intranasal anticholinergics because cholinergic agents are usually secretory. So if you give anticholinergic, it will stop that rhinorrhea and the secretion. So example of that is ipratropium that is not long acting. You can also give the congestant that will constrict the blood vessels to the nose so that you have less secretion, like oxymetazoline and phenylephrine, just like how we treat people with atopic allergic rhinitis. So that's that about treatment of rhinitis. Don't forget, if it's allergic, put in your oral antihistamine, intranasal steroids, can use the congestant and the likes. Here too, the congestant, intranasal steroid, intranasal anticholinergics, and the other stuff. The nasal polyps, these are just like benign outgrowths of nasal mucosa. So they're just outgrowths of the nasal mucosa, and they can be associated with allergic rhinitis, cystic fibrosis commonly, and people with chronic infection. So we should not forget the Samstar's triad. When I was talking about aspirin allergy, in which when they take aspirin, they start having abdominal pain, nausea, vomiting, diarrhea, even some rash. And I said they also have chronic rhinosinusitis with nasal polyps. The Samstar triad, and asthma. So somebody that have asthma, aspirin, hypersensitivity with chronic rhinosinusitis are shared with nasal polyp. That's the Samstar triad. So, people with the nasal polyp, they can present with bilateral nasal obstruction. It will be they will find it difficult to breathe when it becomes big. They can have postnasal discharge. Postnasal discharge means you see like the nasal secretions running back into into the throat. So they start having like watery, sensation in the throat, difficulty, as if something is running at the back of their mouth, and all those things. So that's postnasal dripping. And they can be having like nasal congestion, sneezing from time to time because of the discharge not finding its way to, to pass out. And they can have hyperopnia and anosmia. They cannot breathe well because of the polyps. So how do you make diagnosis? You can do like a coronal CT scan. You'll be able to see the polyps well. You can also do a nasal endoscopy to look at it, what is there. And sometimes, if they don't respond to treatment, you might need to biopsy them. But what is the treatment of nasal polyp? Don't forget, you give them oral corticosteroid, not intranasal steroid. Oral steroid, that's the most effective. Don't forget that. If you give them intranasal, it is not as effective as oral steroid. Sometimes, if it's not responding to treatment, just go and do a surgical removal. Just go and do a surgical removal. You can do your biopsy to further rule out tumor. Moving on to epistaxis. So this is just bleeding from the nose, and it can be anterior or posterior, depending on the location of the bleeding. So the commonest presentation is usually anterior epistaxis, and that's when you have like a bleeding from the Kesselbach plexus. And the acronym for the vessels involved is legs. The superior labial artery from the facial artery, the anterior ethmoidal, the greater palatine, and the sphenopalatine. So the greater palatine, sphenopalatine, anterior ethmoidal, and the labial artery legs. Then we have the posterior epistaxis that usually comes from the sphenopalatine artery or the pharyngeal artery, which is a branch of the external carotid artery. So that could be a potential site for posterior epistaxis. Now, somebody with epistaxis, how will they present? They're just having like nasal bleeding from the nose. What are the potential causes? The commonest cause is nose picking. So people that pick their nose a lot, they can have it. Rhinitis of any cause, facial trauma, drugs that are being used through the sniffing route. They're always sniffing them. Cocaine, intranasal steroid. That will cause atrophy of that mucosa, and they can easily bleed. Or people with some tumors like nasopharyngeal carcinoma, they can easily have epistaxis. People with some systemic problems too, people that are anticoagulants, people that are on, some antiplatelet medication like aspirin, people that have hypertension, they can have epistaxis. People that have bleeding disorders like von Willebrand, they can have it. So how do you manage, epistaxis? So first, you want to ensure, is this person hemodynamically stable? If the person is not hemodynamically stable, you want to do ABCD quickly. Secure airway, ensure the patient is breathing, give oxygen, check the airway, intubate if necessary. Giving fluid resuscitation or blood if the bleeding is very bad. But if the bleeding is not very bad and the patient is still hemodynamically stable, you can just raise up the head of that patient and tilt the head forward. Pinch the two hala of the nose together, and administer like vasoconstrictors like all these oxymetazoline and the likes, just to arrest that bleeding for a while. But if all these conservative measures fail, you now need to do like put in a speculum or a rhinoscope to see what is actually happening, to see where the bleeding is coming from. So once you put in your scope or your speculum, you have to like do a cauterization. And you can cauterize by using electrical method, in which you just put something that looks like a laser, you put in and use electricity, to ablate that area. You can put in a chemical like silver nitrate, you can use that one to also cauterize. So if you cannot cauterize, you can put in laser packing. Packing can also tamponate the vessels and calm them down for some time. So you can pack by using nasal tampons, ribbon gauze, or balloon catheters. If unilateral packing doesn't stop it, you can do bilateral packing. If bilateral capping does not stop it, you just know that the cause of the bleeding is going to be posterior. It's going to be a posterior site. So usually for posterior side, they usually like a bilateral catheter to pack, but most of the time they will send the consult to his ENT to come and do like embolization to solve the problem. And don't forget, the source of posterior bleeding is usually from the sphenopalatine artery. Very, very important. So what are the complications of epistaxis? So what are the complications of prolonged retention of the nasal pack? So if you pack for long, it can cause necrosis of nasal mucosa. It can cause toxic shock syndrome, which we know caused by Staph aureus. Toxic shock syndrome, it can cause sinus or nasolacrimal infection, and it can even dislodge and go back into the airway. So we have to be very careful. So suspect toxic shock syndrome in somebody that's having fever, hypotension, desquamation after packing for a long time. So they will have fever, hypotension, desquamation, and some systemic problems. It could be liver, it could be AKI, it could be neurologic. Think about toxic shock syndrome from Staph aureus. Then moving on to adenoidal hypertrophy. So this is when we have like enlargement of the adenoids at the back of the throat. So, people usually have these and they develop recurrent infection. And that is because if you look at the adenoid, they are like at the nasopharynx. They are like structures in the nasopharynx of the, at the back of the nose. So they are somewhere here, at the back. So in a way, we have like the Alsatian tube running like this vertically, from the nasopharynx, to the, what's it called, to the inner ear, somewhere here. So if you have enlargement of this adenoid, they can easily compress on this Alsatian tube, and that can prevent, movement of discharge from the hair into the pharynx. So that can occlude the Alsatian tube, which could lead to recurrent otitis media. So people with adenoidal hypertrophy, that they have blockage at the back of their nose, how do they present? So because the nose is already blocked, they experience mouth breathing. They always breathe into their mouth. There's voice change. So there's some form of hyponasality to the voice. They'll be sounding as if the nose, they'll be sounding this way I'm sounding. As if the nose has been blocked. They have adenous faces in which you see them. They have like broad, wide. Let me see. I think I have some notes there. Long face. So you see the face is going to be long, lean, with open mouth, short upper lip, and thin nostrils. So once you see that, think about mouth breathing from adenoid hypertrophy. That's why their face is long, lean. The upper lip is kind of short, and the nostrils are thin. Tonsillar hypertrophy and adenoid hypertrophy, I marry both of them together. They cause the same thing. So to get repaired, they'll be finding it very difficult to even eat, to swallow. The voice will start changing. Then they start having symptoms of obstructive sleep apnea because of occlusion of the airway. So when they get to school, they are sleepy, they cannot concentrate, they are having problems at home too, like enuresis, because of the discomfort. They are always bedwetting. They have poor school performance, and they can also have failure to thrive. How do you make the diagnosis? So you do a nasopharyngoscopy. You are definitely going to see the hypertrophied adenoid tissue. And you can also do a lateral X-ray of the neck, But the best next step, if they're having sleep disorders, is what? Polysomnography. Very, very important. So somebody that is snoring, a young child that is snoring, that is having enuresis, poor performance at school, not sleeping well, just go and do polysomnography. And at the end of the day, you might need to do adenectomy to remove the adenoids. So most of the time, like I said, they are going to have recurrent infection, particular infection of the hair. It can affect the sinuses. So treat the infections with antibiotics. You can use your CENTOR criteria to quickly rule out the group A strep, if it's the cause of the infection or not. But most people with recurrent infection, you have to do a, adenotoxylectomy. Just go and remove the tonsils. Just take them out. So moving on to acute and chronic laryngitis. So the word laryngitis just means inflammation of the larynx. And this is very common in people that cough excessively, people that have infection of the larynx, people that abuse their voice, they're always talking, singers especially. People with GERD, in which you have a lot of reflux from the esophagus to the airway, they can have laryngitis. People that smoke a lot, they can have laryngitis. So, for the acute laryngitis, they have hoarseness of voice, because the symptoms of laryngitis include loss of voice, hoarseness of voice, cough, fever. If it's infectious, they have fever, enlarged lymph nodes, and sore throat. So people with acute laryngitis, they have their own hoarseness of voice, less than 3 weeks, but for chronic, it's more than 3 weeks. So you just want to ask for history around infection and all those things to rule that out. So you perform your physical examination on the head and neck and lymph node to rule out malignancy. Then, in selected cases, we can do nasopharyngoscopy to look at the vocal cords, because it could be like we are seeing some lesions, some nodules on the vocal cord. That could be the cause of the what's it called? It could be like there's some form of cancer there. So that could also be a cause of this chronic laryngitis. So do like nasopharyngoscopy to look at the vocal cords. How are they doing? Is there any polyp or any nodule there? And do you achieve bilateral motion of the vocal cords during, like, when somebody's talking or the likes? So if there's no motion, there's something occluding the movement of those vocal cords, so you might need to get treated. So just rule out this underlying thing. Are you a singer? Are you coughing excessively? Are you a smoker? And all those things. So supportive treatment is usually the mainstay. You encourage them to reduce their vocal stuff, but it's not that they have to go silent. Encourage hydration, cough suppression, and avoidance of irritating factors such as smoking. So if they have like GERD, you have to give PPIs, so to reduce the reflux. For laryngopharyngeal reflux, it's just like one of the causes of laryngitis. So this is usually like a reflux of gastric content into the laryngeal tissue. So anything that causes reduction in the lower esophageal sphincter tone or even the upper tone can cause this. Very common in people that take some spicy food, people that have obesity, they can have it. So how do they present? They have dysphonia because of irritation of the larynx, cough, globus sensation of foreign body in the throat. They're always clearing that throat, and they are having dysphagia. They cannot swallow. So what do? Avoid caffeine. Avoid some acidic foods. Stop taking alcohol. Don't take peppermint or chocolate. All these things can cause GERD. Or no, not GERD. Laryngo pharyngeal reflux. So don't take caffeine. Avoid chocolate, peppermint, alcohol, and acidic foods. So behavioral changes too. Tell them to stop smoking, because smoking also increases the risk. And when they eat, tell them to wait for like 2 hours before lying down. They should not exercise, after eating. So don't eat shortly before sleeping. You can also give PPIs or H2 antagonists to reduce the acid suppression. So just start with lifestyle. Avoid these certain foods. Don't smoke again. Wait for 2 hours before you start exercising after you've eaten. And at least you have to eat you have to eat 4 hours before you sleep. So don't just eat now and just go and sleep immediately. There's a high chance for laryngopharyngeal reflux. So there are benign and malignant laryngeal lesions, and these include like vocal cord polyps. So this is a very benign laryngeal lesion, and it's very common in people that use the vocal cords excessively, like singers, teachers like us now, smokers, and people with GERD. They can all develop vocal cord polyp. So they present hoarseness of voice, and in severe case, they can have dyspnea. So they do laryngoscopy or stroboscopy to see the frequency of the vibration of the cords. So the mainstay of treatment is just to encourage voice therapy and to do a microsurgery, to remove that polyp. The same thing for NODU. Both of them, they are the same. You do your laryngoscopy, stroboscopy, encourage voice therapy, encourage smoking cessation, put in steroids or microsurgery. So recurrent respiratory papillomatosis is very important. And this is caused by HPV virus, especially the type 6 and 11. So it's very, very commonly transmitted it can be transmitted, not very commonly, but it can be transmitted from the mother to the child. So, and it's very, very debilitating for the child because you might need to go into the throat up to like 20 times, to remove all those papillomas, because it's more like warty growth in the airway. That is it. So it's recurrent because as they are removing, it's growing back. Removing, it's growing back. That's for the juvenile form. For the adult form, they get it through oral sex. So what are the risk factors for the juvenile form? So people that are firstborn, people that get delivered through vaginal route, and mothers less than 20 years, those are the risk factors. So, but anybody that is that's older than 5 years that have it, they should consider sexual abuse. But because the juvenile form will have manifested before 5 years. So if somebody is now developing it after 5 years, know that it's likely to be sexual abuse. So adult form, the more the sexual partners, the more the frequency of oral sex, they have the tendency of developing the recurrent respiratory papillomatosis. How will they present? Hoarseness of voice change, choking, because definitely the airway is getting occluded. They can have globus, foreign body sensation, stridor, and the like. So you want to go and look into that airway and see what is happening there. And by the time you do your laryngoscopy or your bronchoscopy, we are going to see multiple raspberry-like swellings. Those are the papillomatosis. There's no cure for it. You just keep debulking. So they do like surgical debulking, like the micro debridement, or like they can now use like CO2 laser now. Some patients can also benefit from cidofovir, but the thing is, there's no cure. Just need to keep in with the surgery to debulk those warts. If airway is very, very significantly occluded, you might need to put in a tube, tracheostomy. But the best way to prevent it is to vaccinate through the quadrivalent HPV vaccine. Don't forget, this guy is transmitted through, exposure to the human papillomavirus 6 and 11. So, with that, we come to the end of the respiratory discussion. Do you have any question? Any question from anybody? Okay. In the absence of question, we'll call it a day, and we're going to meet on Monday to start our multi-system. Thank you, everyone. Enjoy the rest of your day.